specifically the practice of telemedicine by licensees of the North Carolina Medical Board, created a situation where our rule 1801B, as in boy, arguably was in tension or conflict with the medical board statements about what constitutes an appropriate interaction with a patient to prescribe a drug. As a result of that, working in consultation with staff at the medical board, you reviewed and published for notice and comment a series of amendments to Rule 1801 that would harmonize the statements in Rule 1801B with the medical board's views on appropriate medical practice. By way of background, the intent of Rule 1801B has always been to have the pharmacy boards and the medical boards speaking with one voice with respect to what constitutes acceptable medical practice for the generation of a prescription. The rules have been published for the requisite period of time for notice and comment. Board staff received one comment and only one comment. I'll read it back to you, and I'll try to make a comment about it. But this time I went straight to the website and was able to see the changes, which appear to be all deletions and nothing added. If that's the case, I approve. If, however, the wording is changed to imply or state that we are simply falling in line with other boards, medical, nursing, veterinary, etc., or just following what their rules state, I reject this. When I read the email, it came across as the latter, which felt like handing over the reins to someone else's practice, which may or may not agree with me, understand our issues, or have properly considered all potential pitfalls. But this appears to be a simple cleanup, which is always refreshing. With response to that comment, which I think I would characterize, I guess, at the end of the day as one supportive of the rule change, but to the extent there was concern that the rule could be read as saying pharmacists have given up, by virtue of this rule, in some way their ability to make their own professional judgments about the appropriateness of a prescription. That is certainly not the case. In fact, both paragraphs A and B continue to state explicitly that pharmacists continue and have always had the ability to exercise their independent professional judgment and refuse to to dispense a prescription if they do not feel it's appropriate. So that was the only written comment. I have not received advanced notice of anyone intending to speak to the rule amendment at this hearing, but that doesn't mean that there might not be somebody who wants to speak to that rule amendment. Certainly, Mr. President, now would be the time. If there are any.
Is there anyone here who would like to speak to this proposed rule amendment in the spirit of the Open Meetings Act? If not, the letter. Hearing none, I are seeing no.
Then I would, Mr. President, declare the comment period closed on this particular rule and our proposed rule amendment, and that would mean it is now in a posture for action by the board, and the board's options would include to approve this rule as written, and it will then move over to the rules review process. The board could take the rule under advisement and think about whether to take an action on the rule at a future meeting, or the board could decide that it does not want to go forward with the amendments to Rule 1801.
And this would take a motion from the board?
It would indeed.
Any discussion? motion to approve?
Mr. President, I move approval.
Second?
Both sets.
Second.
All in favor? I think that's consensus. Minutes are approved.
Thank you, Mr. President. And I would, next time I'd like to invite Patrick Brown. Come on up. Now, most of you remember Patrick. Patrick graduated, what, 2 years ago now? You can sit whichever place you want to.
Yeah.
2 years ago now, graduated from UNC, and Patrick did, he's from Ashboro, so if this end,
How could I ever forget him?
yeah, whatever secret signals you guys want to give to each other throughout is certainly fine.
He goes further back than Ashboro. We go all the way to Robbins.
Indeed.
But Patrick did a rotation here at the Board of Pharmacy, so a lot of you remember Patrick within, and I will say for the record, one of the finest students I ever had come through here. Don't be offended, Alan, you were too. You got the permanent job, Alan, so you got. But Patrick is here to talk about, Patrick's doing an academic fellowship at the UNC Eshelman School of Pharmacy, and we have all talked about this a couple times, although Robert and Stan, you sort of coming in at the tail end of this. As I think everybody on the board knows, the appropriate use of the North Carolina Controlled Substance Reporting System has been an issue of great interest, certainly to the legislature and to policymakers generally. There's an ongoing state task force that is endeavoring to bring some continuity and cooperation to statewide efforts to reduce inappropriate use of prescription drugs. Ellen's been serving on that task force. She probably curses me daily for having to do that. But I have reproduced or attached to your materials the board statement, which put out about a year ago, a little more than a year ago, concerning the board's expectations with respect to use of the Controlled Substance Reporting System as a regular part of pharmacy practice. You'll also recall that we did some surveys a couple years ago of pharmacists in the state. Why don't you use the CRS, or why do you, why don't you, what are the barriers, et cetera. One of the barriers, of course, we ran into is there just weren't many pharmacists who were even registered to use the CSRS. And with your guidance and support, we've implemented a number of things that have improved that. Now the feedback we get from pharmacists in the field is, I have the access to the Controlled Substance Reporting System. When I'm looking at this massive data, I'm not sure what to do with it. And one of the things that we've been looking at, and Ellen's been talking about the task force, is what is it that the Board of Pharmacy could do to help pharmacists be able to better use this tool? So I approached Patrick and discussed whether the UNC Eshelman School of Pharmacy, which has all the equipment, the video production equipment, et cetera, would they be interested and available to put together a CE module? Actually, it'd be a couple of CE modules, I think, at the end. Well, largely one, but that would do two things. One is kind of orient pharmacists as to how to get access to the CSRS if they haven't done already, but more importantly, to orient pharmacists on, now that you got a patient in front of you and this data on a screen, what do you do with it? How do you make the best use of that in your practice? And so Patrick and his colleagues at UNC have come up with a proposal for your consideration. And Patrick, I turn it over. And all of you have this proposal, of course, behind you on your website.
Sure. So I won't take up a whole lot of your time talking through the specifics of what we're planning to do. I'll just give you a brief overview and then field any questions to the best of my ability. But basically, our thought is that through this proposal, we would work with the academy at UNC, at the Eshelman School of Pharmacy. And the academy, if you're not familiar with it, is a team of educational designers, web developers, programmers. So they're not pharmacists by training. They are led by faculty from the School of Pharmacy, but they're all staff whose expertise is distance-based learning, educational design, how to put this stuff into a more kind of modern, technology-friendly format. And so our idea is to work with them in the CE office at UNC to put together a 1 hour long CE granting module, for lack of a better term. Our intention is for it to be very interactive in nature. If any of you have had to do any sort of onboarding online training for any services you've ever done, where you kind of get a little bit of content and then it gives you a little pop-up question, and you click, and once you click the right answer, you can move on to the next thing. That's sort of the overall philosophy of where we want it to go. We'd love for it to be as interactive as possible, to kind of promote some real active learning in it, so that it's not just a computer screen and a voice that you're hearing for an hour and then you're moving on to the next thing, like a lot of these distance-based CEs are. The overall sort of layout of it would be after the brief introduction, the first 10 to 15 minutes, we're hoping that we can embed a already produced nuts and bolts video that says, here's how you log in, this is what you do if you've forgotten your password, here's how to search the patient, here's what the report will look like, as sort of just some refresher on those sorts of things. And then we want to move into 3 practice-based cases where we'll present as realistic of a case as we can, based on some pharmacist guidance to design the cases in a community pharmacy setting, an outpatient clinical setting, primary care, pain clinic, something like that, and then an inpatient setting, which we're thinking will likely be through an ED admission or an ED visit and then through to the admission, so that you can follow that through. And so the intent would be that about 40 to 45 minutes of the hour-long module would be working through these 3 cases, so that pharmacists in different practice settings can get not only exposed to how it works in their practice setting, but can also have an understanding of how it works in other parts of the profession, so that if you are seeing somebody who's coming from a pain clinic who's seeing a clinical pharmacy practitioner or something of that like, you have a little bit more of an understanding of how they may be using it as well. We plan to reach out to 3 pharmacists who are practicing in these settings for guidance on the case design based on their experiences and real world, practical issues that they come across. And then another person who has already agreed to work with us on it pending approval is John Valgus from UNC Hospitals, who has a background in palliative care in the cancer setting, but this is sort of and he's going to serve as both a case author and is going to do the content delivery for the video. So it'll be his voice sort of guiding you through the video and providing sort of the case scenario, the background content, and then we'll give the pharmacist the opportunity to sort of click through and move on to the next thing. We're hoping that pending approval will have it ready to go right around the time of the NCAP annual meeting, so that we can do a big push to let people know about it then in October, and so that it'll be available at the end of the calendar year when everybody's scrambling to get those last few CE hours, like I'm sure I will.
One thing to point out to that, and Patrick may have touched on while I was whispering back and forth to Clint, so I apologize in advance, this would be an ACPE, it would also be an ACPE approved continuing education course that we would make available to pharmacists in the state without cost. So we would publicize this through our board website. I would publicize it at every talk that I give. School's certainly going to publicize it. And pharmacists would be able to come. I mean, there's no greater hook to get somebody to come and do one of these things and say, hey, you get free CE for doing this as well. So that's the plan. And you see on the second page, there is a budget overview and total production costs that UNC estimates, with one possible thing that we can talk about in a second, is roughly $6,500 in production for this. If this were approved by this board, for the board to expend $6,500 to do this, I assure you, as you will hear later in the financial report, this will not materially impact the board's standing at all. We certainly do have the money available to do that. The one cost that could crop up is if there's a huge uptake. I think I understand that UNC, as the ACPE accreditor, might incur some costs from ACPE based on uptake.
Right. So basically how our CE office at UNC works, from what I understand, is that we are billed every year by ACPE for the total number of CE hours that we grant through whatever events UNC holds in person and sponsors the CE credit, as well as anything that we do distance-based, the Pharmacy Grand Rounds program, which is relatively new, and things like that. So the only added cost that could come into play if there is a large uptake in this program, which we hope there will be, this would be a very good problem to have, that we could be moved up into the next bracket of ACPE billing. The nice thing, however, is that bill is months down the road for them to get it next time, and it's itemized, so we would be able to see how much of our increase is through this program, and then we would sort of need to move forward that I haven't gotten the exact number yet. I'm still working on getting that, but from what I understand, it's not something that's going to double or triple this proposal's budget by any means. But we would be able to see the impact that this program had on moving us up to that tier, so that if we incidentally did move up, but it wasn't because of a huge upswing in this, and it was because we picked up a new large statewide meeting, or the Pharmacy Grand Rounds program really took off, that we would be able to distinguish the two, and that would reflect appropriately.
And my suggestion would be, with respect to that, my suggestion to the board would be to consider the costs that have been budgeted in this proposal, the $6,500, and then what we could do is, as we're planning budget for fiscal 2015-16, we could build in some money in that for next year to cover a ACPE cost if we need to. But my personal opinion is that it's important that if the board does this, we are doing this as a public, and we're going to make it available to pharmacists.
Is there any idea what the ACPE cost would be?
I have gotten a sort of vague idea, but I don't want to guess at a number and be completely wrong. So we had a meeting last week to sort of shore up some of these details, and I haven't gotten that number back yet. I will try to follow up on that this afternoon, and I can circle back around.
What's the worst case?
I really don't.
I think we're not looking at multiples of this cost. It would seem to me that your worst case scenario, you're looking at something $5,000 or less for the entire fiscal year of next year, and probably not something approaching that.
That's doable.
Yeah. Yeah, we're not going to get hit with $100,000 ACPE.
Let me ask a side question, since I'm ignorant in technology, as Patrick knows.
Here comes the crazy like a fox portion of the meeting.
Is there a way that a pharmacist working in the store, when they the controlled substance webpage, is there a way that we could interface with a patient's profile, so you'd only have to click one time to get to that screen, and then not have to put all that information back in again because it's already there?
That's a great question that only Alex Asbin and his folks over at, what I would suggest we could do, Mr. Haywood, is that if we want to, we've worked with them on different things. We worked with them to open up that electronic portal for registration through us. The challenge with dealing with DHHS on this sort of thing, or the challenges that probably doesn't take a lot of imagination to figure out, is that it's be careful that you stick your toe in that pool and all of a sudden you're sucked into the vortex.
Yeah, well, you do have to be careful, but at the same time, if you're going to
you need to
really
be a
get
useful
people
tool.
using this
That's
thing,
correct.
the ease of using it needs to be changed.
No question, and I do know, Mr. Haywood, that there is some discussion, and you may know a little bit more about this, Ellen. There's some discussion over there. Apparently, they have some IT changes that are underway now, although I think that's geared more to registration than it is to access. But Ellen sees those folks, and I think we can jot that down, and the next meeting we have of that, I think that's a very good question to ask about what are the potentials for making it a more user-friendly interface. It's a great question. And then we'll see what the elaborate explanations are. If you're asking us, could we do it at the board, the answer would be yes. It's not our system.
I know.
Yeah.
And that's probably what a lot of people going to run into is proprietary issues there as well.
Yeah, yeah.
With software.
But that doesn't mean, though, Stan, that there couldn't be a discussion to be had with the CSRS people about whether or not it could be integrated into individual pharmacy software systems, but still talk to them about what CSRS's interface itself is, it's a discussion well worth having, in my opinion.
I think that there's some initiative going on now, some of the pharmacy software systems, to where your login information becomes part of your login there, and they are
Great.
looking at that currently.
That's great.
I have a question in regards to this proposal. Is there somewhere in this thing there's gonna be some more input from other practitioners, board members, as you build this program, or I don't see anywhere you've got anything noted about that?
There very much can be. We haven't gotten into the specific timeline of, when we're going to start the writing the cases and building out the content and everything. But if the board would be more comfortable in reviewing it before a go live date, I don't see any problem in working that into the timeline.
I think y'all have hired, or you've got folks you've identified who are experts in each of the different fields, who are practitioners who are going to have input into developing those cases. But that would be up to the board. I mean, the balance we would draw is, but how we can have as much input as we want, as long as we're all comfortable with what that does to timelines and the like, particularly over the summer.
I think part of the program needs to be, I guess, in like the introduction or something like that, be explained to pharmacists that one of the reasons behind the board's initiative here is because if we don't do that as a function of our regular everyday practice, we're going to be mandated by the General Assembly, probably without consulting us about that.
Right.
So I would think that you would make sure that you took particular care to make sure that was introduced in the program somewhere.
That's
Absolutely.
a great point, Gene. And in fact, we've had that discussion over at UNC that's one of the points of this. And Ellen can tell you, part of what we're trying to do through this task force is to be proactive on these things to avoid exactly that, that consequence. But I think if it's okay with the board, that my working with Patrick as they develop the scripts on this to make sure that point gets emphasized, because that certainly is a driving motivation behind it.
And we do have a short in the storyboard document. I can't remember if I included that in the proposal or not, but there's a short 5 to 10 minutes or so that we plan to have as sort of an introduction to a very brief background of how this came about and the priorities of both the system as a whole and the board's priority in developing this, which is exactly to your point that we would hate to see a mandate come down that would bring pharmacies everywhere to a screeching halt in productivity. So we're very keen to that fact, and we'll absolutely can develop the scripts out for those and have the board review them before they're finalized.
Well, I guess our primary priority would probably be enhanced patient care, but its
Right.
subset priority might be that, but it wouldn't be the only priority
Right.
for sure. Yeah. Do we need to basically then at this time consider a motion that has a budget, a figure that we don't really know what
Yeah,
it is?
Mr. Min, we could arguably shoehorn this into an existing line item on the budget, but for purposes of transparency and consideration, I'm much more comfortable that if the board is comfortable with this proposal, that we get a motion to approve this expenditure as an add-on item to the fiscal year 2014-15 budget.
Should we also have a figure that might incorporate some costs that we anticipate but we're not sure of?
The ACP, those costs would accrue, if at all, in 2015-16.
Okay.
So my recommendation, Mr. Minton, and you're certainly as a member of the Finance Committee, my recommendation would be that we take that up in August when we have our planning session for that budget. And by that point, I think we'll have a very firm idea of what I don't want to say worst case, because we're not looking at some Titanic potential liability, but what the range of potential cost is, and we can factor that in.
And you're gonna bring some back to the board oversight of what you think is going on in this program, so we will have some potential input, is that right?
Absolutely, absolutely.
Mr. President, this time I move that we adopt this proposal with a budget amount of $64.85 at this time.
Okay, we have a motion on the table. Is there any discussion? Do you have a second?
Second.
All in favor?
Aye.
All opposed? Any opposed? No opposed? No opposition? Very good. Congratulations.
Thank you, board members. Thank you, Patrick. Patrick, you and we'll round back up.
I'll follow back up sooner than later about that ballpark number so that you all can be thinking about that moving forward.
Get started on the production. Well, at least, Alan, we can report now to the statewide committee that moving forward. Thank you very much,
Thank you all.
Patrick. Give me a second, Mr. President, to shuffle my.
No problem.
Next item on the agenda, board members, we have, as you know, I don't have to reintroduce the whole thing about the FDA memorandum of understanding that's been proposed between the states, between FDA and the states concerning the regulation of the distribution of, quote, inordinate interstate distribution of compound pharmacy products. And we, of course, have had a couple of discussions on this, and I prepared a memo and gotten great feedback from some of you about various points on this draft memo. What you have behind your tab is a letter that incorporates those concerns that we have identified over these past couple of months with the memorandum of understanding, and in my view, as importantly, or if not more importantly, have taken your input and made specific suggestions as to how those practical concerns could be addressed in the memorandum of understanding. So that letter is before you. Of course, you got it a couple of weeks ago as well. The one wrinkle, if that's the right word, the FDA did last week extend the comment period on the MOU to July 20th. And we can take that time up to July 20th if that's the board's pleasure. I would make a request that if we think we've sort of arrived at what our opinions and suggestions are, my suggestion would be that we go ahead and act on this and go ahead and send in our comments. July 20th is the day before the next board meeting, so we're not going to have another regularly scheduled board meeting between now and the deadline anyway. However, if you would like to further consider this, you absolutely can, then we can do that, and we could convene a conference call meeting between now and the 20th to do that. So your pleasure on this. I'm happy to respond to any questions that you might have, and tell me what my directions are on this one. I can add one other potential wrinkle, just as an FYI. There was a bill introduced by Senator David Vitter that would make certain amendments to the Drug Quality and Security Act, and one of those potential amendments does speak directly to what the memorandum of understanding might be. I will send out to each of you that draft legislation. It makes for very trenchant reading, I assure you, since there's a whole lot of substitute this clause for that and the like. But I did review it in depth last week. I don't think that should inform our immediate decision of how to comment, because it is a bill. Whether the bill gets passed, who knows? But one thing I'm pretty confident of is if any bill gets passed to amend the DQSA, it ain't going to happen before July 20th of this year. So my suggestion would be keep monitoring that, of course, and it could make a fairly fundamental change in what the MOUs might be. But in the meantime, deal with the problem in front of us and deal with that one if we need to.
Mr. Campbell, does your letter pretty much follow the format and the suggested changes from the NABP letter?
In gross, yes, it does. We have some more specific suggestions. I would particularly point the board to our proposed comments governing the calculation of the 30% threshold. I think the NABP suggestions do recommend going to number of prescriptions as being the unit, the otherwise undefined unit, which we mentioned here as consistent with the statutory language on that. But our comments go a little bit further, and some credit, this is not a new thing, some credit here to Joe Caballero who raised this issue about how overall the formula sort of ironically almost makes whether or not you hit that threshold turn more on your non-compounded product distribution than on your compounded distribution. And so there was a very good point that I felt that Joe raised, and so we do go into more detail about that particular effect or consequence, and I give this example, and again, I don't take any credit for this pharmacy A, pharmacy B thing. That was Joe's way of demonstrating the issue and pointing out that it does raise some potential consequences, especially for specialty infusion pharmacies and the like. So it goes more in depth on that particular issue. Again, I don't know that necessarily says there's a conflict between what we're suggesting, but I think we treat it in more depth than the NABP comment does.
I think the letter's well written. I'd like to encourage the board to encourage Mr. Campbell to send this on.
I have figured out just procedurally, if it's the desire of the board that we go ahead and submit these, I will submit it by paper, of course, but there's also an electronic submission, and all the comments that are being submitted on the proposed MOU are available electronically, and I have been monitoring those. Most of the comments so far are from individuals, and they're very short. In some cases helpful, mostly not helpful, sort of this is the worst thing in the world, or this is the best thing in the world, with no sort of nuance to it. But I would certainly also submit these electronically, because I do think it's important that other stakeholders out there see what your comments are on this, because other boards of pharmacy do look to us in many ways as sort of showing the path on certain things.
Do you need a motion from the board?
Yes, this would be a board communication, so I would need specific authorization from the board to submit the comments on behalf of the board.
Mr. President, I make a motion that we take the recommendation of Mr. Campbell and the letter he wrote to forward it to appropriate channels.
That's very good. Any discussion? We have a second. All in favor? Aye. Unanimous.
I will get that submitted by the end of this week, Mr. President. And I will do a couple things. So I will not only submit it, but once it's submitted, I will send an email to each of you with a link to where all the electronic comments on this are being posted.
I appreciate that. I'd
Yeah.
particularly like to see that
It's,
or have that.
it's not easy to find. You'd be shocked to learn that the Federal Register website is a little bit counterintuitive, so it took me about 20 minutes of digging to figure it out. So I'll give you a link.
Precisely why I'd like to have it.
Very good.
The next,
Thus it shall be done. Next, I'd like to invite Jason Southworth to come up. I think most of you remember Jason, who was here a couple of months ago. And Jason is here to present a Rule 2510 pilot project proposal, which you guys have had. I'm sorry, I'm having computer issues. I'm also, by the way, if you see me doing this all day, I have bifocals for the first time, and so I have not developed some sort of seizure disorder. I just can't figure out.
Welcome to the club.
Yeah. So Jason is here to present a proposed pilot project for telemedicine in his clinics. And again, you'll recall Jason was here, I think, in March, I believe, to talk about some thoughts. And he has developed a project. Just by way of background, probably Robert more for you than anybody else, because most of Stan remembers pilot. We had some pilot projects when he was on the board before. But Board Rule 21 NCAC 46.2510 allows the board to waive enforcement of certain rules to allow a project that would otherwise be prohibited by existing pharmacy law to go forward. So long as, and there are 4 criteria to look at, that this departure from ordinary practice is designed to have a positive impact on the delivery of pharmacy care or to reduce healthcare expenditures. Number 2, that patient health and safety will not be compromised by the waiver. 3, a policy and procedure manual detailing the project, essentially, which is what Jason has submitted. And number 4, the waiver is subject to continuing compliance with the conditions approved by the board. So those are the 4 criteria that the board would use to assess any pilot project, this or any other pilot project. So with that, Jason, thank you. Good to see you, and I will yield the floor.
Thank you. as Mr. Campbell has mentioned, you know, we were here in March and we had us and you had a very long and I think meaningful discussion about telepharmacy and what our thoughts and views were on it and what we were looking to do going forward with with this. At that time, I think it was left that the board had mentioned that they would base every case of telepharmacy based on merit is what your guys' I think conclusion was when I left here in March. After we left here in March, myself and Dr. Millet went back and had several lengthy discussions on telepharmacy and what we thought we wanted to do with it going forward and how we could implement it into our practice. And looking at the Board of Pharmacy Rule 2510, the waiver enforcement, and we came up with this project or this proposal to you for that waiver. We feel that our waiver enforcement will ensure that patients have access to cost-effective care, timely patient education at a convenient location that will encourage medication adherence and improve overall health outcomes for our patients. As we mentioned we heard before, our patients are all behavioral health patients, which this group of patients are some of the patients that don't adhere very well to their medications. They eat up a lot of healthcare dollars. And since we implemented a pharmacy in 2 of our clinics previously, we've found really great success with these patients as far as keeping them on their medications, improving outcomes, keeping them out of the hospitals. And so we wanted to duplicate kind of what we were doing in one of our other smaller clinics that we don't think that could sustain a normal pharmacy, as you could say, by itself. And that's where we came up with the idea of using a telepharmacy. And I'm sure all of you are aware, and we had this discussion before, telepharmacy isn't a new idea. It's being used right now in more than 50% of the states across America. So we feel that it is something that's been out there for quite a long time. It was first used back in North Dakota back in the early 2000s. So a lot of the data that's out there shows that it can be used safely and effectively in patients. And so therefore we are coming, like I said, to you guys today for a waiver of enforcement to allow us to work with you, the board, and implement a telepharmacy in one of our clinics to hopefully duplicate some of the outcomes that we're getting with our patients in our clinics that do have pharmacies. Do you have anything to add?
I think one of the most salient comments that was made at the March meeting was Mr. Minton brought up the idea that would a telepharmacy supplant or take business away from the local community pharmacy. And I just want to make the point that for our patients, we are their community pharmacy. They get their mental health medications as well as their general medications filled at our pharmacy. We generally see them once a month, so when they come back for their regular appointment, we fill their medicine. So we think we are filling the role of their community pharmacy. And
Are y'all pharmacists?
I'm a physician.
You're a physician?
I am a pharmacist.
Okay. I just wanted to be clear. I wasn't here in March.
Yeah.
So the idea is that we are the community pharmacy for our patients.
What's too is we're finding in our practice as well too with our mental health patients is that even the clinics are changing for our providers as well as we're really moving towards the whole integrated care. When you used to have you saw your primary care for one thing, and you saw your mental health doctor for something else, and maybe your GI doctor for something else. We're finding a lot of our patients don't seek outside primary care, that they basically come to us and us only, and that they are coming to us and asking those primary care questions as well, and they're not seeing their primary care, and they're looking to us for that. And so us as a clinic as well, we're also looking to expand into more integrated care so that we will be taking care of these patients, all their total needs in-house, and then we feel like bringing pharmacy into that kind of brings it all together into one place for them.
And I think there was another comment, I forget which board member made it, but but brought up the idea of, I guess there's something called doctor dispensing, where maybe the doctor could dispense meds, and I just want to say, I think that's a terrible idea. Our patients sort of depend on the pharmacist to answer questions about their medications, and I think the pharmacists do a better job than the physicians, and I think the pharmacist is there for what I call the callback, right? I mean, you see your doctor, you get bombarded with information. A day later, you get home, you look at your medicine bottle, and you have a question. I think the pharmacist is the best person to answer that question. And just one last comment. Most of my research has to do with medication adherence. And we talk a lot about insight, and we spend billions and billions of dollars trying to improve patients' insight. And actually, it turns out the relationship a patient has with their healthcare provider trumps insight into their illness when it comes to whether or not they're going to take their medication. So we think this is a very good idea. We'd like you to consider it based on its merit. And we think it will improve the care of our patients in the Hillsborough office.
Jason, do you want to talk about some of the specifics of the proposal, sort of walk the board members through the plan, what the setup is, the technology, that kind of thing? I know it's all in the proposal, but.
So as far as the technology, I'm not a technology expert. There are, systems out there that do the telepharmacy stuff. There are telepharmacy companies. I mentioned one in my proposal, Telepharm, which is one that they have a system that integrates right into we currently use RX30 as our pharmacy software system. It integrates right into that. And so we'll have that as a telepharmacy separate system. Basically, what that system does is once the prescription has gone through the whole process of being, filled, checked, dispensed, whatever, the prescription moves into that system where then it connects it into a audio video feed with the pharmacist. And so it sits in that system until all the telepharmacy stuff's been taken care of, and then it moves back to where the prescription can be filled once that's all done. So basically what I did to come up with this is I did quite a bit of research and talked to several different states that already are using telepharmacy and kind of looked at the different operating procedures that a lot of them are having. I won't touch on everything that is here, but some of the stuff that I highlighted is that, that I like to highlight, I should say, was that we will be a closed pharmacy. We're not looking to have anyone be able to walk off the street and come in and use our pharmacy in Hillsborough. Because it will be a telepharmacy. It will only be for the patients that are there. They can get all their prescriptions filled there from all outside physicians or any physicians. But if they're not a patient at the Hillsborough pharmacy or Caroline Behavioral Care Clinic, then they cannot use the pharmacy there. There will be a sign posted, like I said, that says that this is a telepharmacy site. That there is not a pharmacist on site, but one is available to speak with you at any time. And that I also put in there that it will be required that the pharmacist speak with you every time you pick up your medications. It won't be just a simple, do you have any questions or concerns or, whatever the normal thing is. The pharmacist asks their patients about their medications or would you like to speak to the pharmacist today? It's going to be an automatic thing where they have to speak to me to pick up their medications. And that way, we feel that way too, that we'll make sure that the patient understands their medications when they're leaving. Because a lot of times, like Dr. May said, they get bombarded when they see a physician. They don't think about the questions they have until they get home, and this way it will be an interaction that they will have with a pharmacist, even though there's not one on site.
How many sites you gonna have?
Just one, right now. I mean, we only have one. Right now we have 3 clinics, and we have 2 of our clinics have pharmacies in them. One of our clinic does not. It's just it's a smaller clinic than the other 2. We only have about 1 provider on at a time.
You have one pharmacist at one of the clinics, and then.
Well, we have a pharmacy in our Pinehurst clinic, and we have a pharmacy in our Durham clinic. And we
Pinehurst clinic close to the golf course.
Fairly close. Close enough.
I just wonder if the pharmacist is going to be out on the 15th when he gives information. I don't know. I'm just asking.
Yeah, well,
So the pharmacist that would staff the Hillsborough Clinic would actually be Jason out of the Durham office. We have no plans to involve the Pinehurst
I got
office.
you, okay.
And just to make sure that we've answered your question, we're only asking to do this in Hillsborough, no other site, where we think the volume of prescriptions is going to be somewhere between 40 and 50 a day, which would not support a
What,
pharmacy.
15 minutes away from Durham, Hillsborough?
About 20, 25 on the interstate.
I put in here to, basically, so how the procedure is gonna work. The prescription would be electronically and/or paper sent or faxed into the pharmacy in Hillsborough. The technician would receive that prescription, would enter it into the system. The pharmacist then would verify the prescription, myself in Durham. Once it was verified, the prescription would then be released in Hillsborough to be checked. The pharmacist, or the technician in Hillsborough would then, scan the label, scan the barcode of the drug to make sure they were correct, fill that prescription. There would be still photos taken of the bottle that she filled it out of, the prescription vial that she's filling it from, prescription of the photograph of the prescription, and then the screen of the prescription on there that would come back to me through the telepharmacy system. I would be able to look at it and see that everything, verify everything. If I needed more pictures or wanted a cleaner photo, she could retake all those. They're using digital cameras, so you have a very clear photo. Then once I okay it, it transfers it over to the telepharmacy system, which then, if the patient is waiting, the technician will grab the patient, bring them into a separate closed private counseling room where there'll be like a monitor and a microphone. I will be in the pharmacy as well in an area where I will have a monitor and a microphone to be able to talk with the patient, answer any of their questions, discuss the medications with them. And then once they were done with that, they would come back out, pay for their medications, and then leave. So it's basically the same sort of interactions that go on in the pharmacy during the day, except you have that extra step in there of the patient interacting with the pharmacist through the telepharmacy system. Some of the other things that I put in here, that I would be over there at least once a month for going through the records and looking through stuff, doing inventory counts, basically quality assurance stuff. We would keep track of the number of prescriptions dispensed every month, the number of medication errors would be documented, document any remedial training to prevent future errors, any loss or diversions of inventory, which there will be a security system on cameras in the pharmacy in all the different areas, being able to get a total picture of the pharmacy, so that we'll always have security cameras to watch any kind of diversion or anything that would go on, which we hope doesn't happen,
At the telepharmacy site in Hillsborough, will the prescription actually be filled by a robot, or will a technician actually fill
A technician will actually fill it.
Okay.
And then also with that monthly quality assurance, we'll do a random, count of some controlled substances, whether we do 10, 20, just pick random ones every month to kind of check them. And then I think I put in here too that we would do, instead of doing I think the board requires a C2 count every 2 years. I know I do it every year, but we would do it every 6 months as well, just as a quality assurance thing, that we would do a total C2 count in the pharmacy, just to keep.
And I would assume at the Hillsborough site that all types of prescription drugs would be available to the technician.
That is correct.
Okay.
Just from what we see ourselves doing now with a lot of our patients, because we don't see a lot of kids, we don't do I don't do any reconstituted stuff except for Quilivent. Is about the only reconstituted medication that I carry in our pharmacy in Durham.
Which one, I'm sorry?
Quillavent, which is methylphenidate, extended release liquid. So we don't do like any antibiotics is what I'm getting at.
Does the technician check the drugs into the site, order the drugs, check them in, do the record keeping?
In the telepharmacy,
Yeah.
yes, we would have her do that as well.
And how often would they then be inventoried or checked by pharmacists?
Well, that's what I put in here, that I would do a monthly quality assurance to go over there and check all those, go over everything, and then we would do a random kind of control count on a limited number of drugs every month, but then do a complete, at least C2 count every 6 months. But if the board wanted a complete control count every 6 months or once a year, we could do that too.
Well, the reason I asked the question, when I was on the board before, one of the great problems that we had was technicians ordering and checking in drugs and then disappearing with drugs.
Diversion.
So I'm just
Sure.
trying to understand what's going on at this site.
Yeah.
Or what will be going on.
Yep. I mean, well, that's part of the thing. I think having what I put in here is like the technician. I don't have anyone in mind now, but the
Like in hospitals, they do a C2 count every shift change.
correct.
So you feel 6 months is often enough?
I was just going based on what the board's current recommendation is and narrowing that down. If the board recommended or wanted to recommend that we did it more often than that, then I would be open to that as well.
And I remember Dr. Dennis used to talk about when one pill was missing, they stayed till they identified and accounted for that pill. And sometimes it took hours. So I'm just, like I
Sure.
say, I'm wanting your background. I want to understand what's going to go on there.
Sure. Yeah, I mean, this is the proposal I put forward is what we want to do. We definitely want the board's input on this, and we're willing to adjust anything that you feel would be more appropriate for us to do to approve this waiver. We're willing to work with you on an ongoing basis for this to be approved. And so any changes or any recommendations that the board would like to make or would say that we would have to do, we would be open to.
In your operations at remote site dispensing, you say the pharmacist will speak with you each time you picked up a prescription or you pick up a prescription. What is that conversation like?
Well, it would be, Mr. Jones, today, we filled for you your Abilify and your Celexa. Either if they were new prescriptions or refills, is that what you're getting today? Was those two medications? Do you have any questions or concerns with me on your medications today? We know you've been on these in the past. Have you noticed any changes or any problems that you may be having now? Basically, just a simple conversation that they know, that I know, that they're there to get the two medications. These are the two that we filled for them and dispensed for them, and just to make aware that we're there to talk to them if they need to and give them an opportunity to discuss with us.
Is there going to be any discussion about over-the-counter meds with this patient? Because this Abilify and Celexa patient may go by the local health food store and pick up who knows what.
Right.
Is there going to be any conversation there? There needs to be.
We can, yeah. I mean, we can talk to them about, the one good thing is with being in there, we have access to the EMRs as well too. So a lot of these patients we know our providers, while patients aren't always honest, and when you ask what medications they're taking, they don't always mention they're over the counters.
I guess
But-
having practiced this profession since the late 60s, I'm a bit skeptical, is
Sure.
a good word.
I can understand.
But what bothers me is a technician gets in the routine of saying, any questions for the pharmacist? And the technician, the patient has no idea what questions to ask, first off, and
Sure.
they'll say no. And so the pharmacist just keeps working.
Well, that's why we made it to where that they have to talk to the pharmacist.
And I'm just trying to figure in my own mind that there needs to be, in my mind, some safeguard each time to do a complete medication review
Okay.
of prescription items and non-prescription items, and ask some leading questions, some closed-ended questions that would prevent them from a simple yes and not really knowing what they're saying yes to. I'm just basing this on my experience of a
Sure.
lot of years in this business.
Well, I think you're exactly right. Sometimes simple things is what saves a life. So in our pharmacy, our pharmacists have access to the patient's record that I have access to as a physician. And we're trying to really improve the medication list, because I think the one thing we all need is an accurate, up-to-date medication list. So we now have a policy that every patient in the clinic, when they come for a visit, meets with a nurse, a registered nurse, who updates their list of medicines, both prescribed and over-the-counter. And before that patient sees the physician or checks out and then sees the pharmacist, that list is updated in the computer.
And it's real time.
Real
There's
time,
no lag.
and the only way it's real time is you have to sit with the patient and get the list.
Absolutely.
You can't just give them a form to fill out.
Yeah, especially if they happen to be a little older like me. We don't like forms and we don't like technology, and there's a lot of stuff we don't like. But we do like somebody to sit down and talk to us.
Absolutely.
That's a big thing.
And my patients always turn to their wife and say, "Now, honey, what medicines am I on?" Yeah, so all kind of ways to get the list, but I think there needs to be a human interaction, and our pharmacists will have access to that.
That's why I take my wife with me. She just answers the questions, and I don't have to say anything. You know?
I'll stipulate to that for the record.
Careful.
I mean, one of the ways we're trying to improve things too is we're going to all electronic prescriptions as well. Our providers are just finalizing. They're all getting their, what are those things called, you guys?
A fob or
A fob little thing to where they'll be able to start prescribing controlled substances now too. So we're going away from paper altogether in the clinic too. So everything will be electronic. We're just finishing up these fob things that they have to
It's
have.
like an electronic,
Number that you get, you push the number and they have to type the number in that shows up, and it's a different random number that shows up every time that they have to type
Yeah.
into our EMR. So
banks have been doing that for
yeah,
years.
so we're finishing up that process now with our EMR. We're company and trying to get that all done. But most of our physicians now, our providers all have their fobs, and so hopefully eventually too, it'll be a little bit better that everything will be electronic. There'll be actually no paper scripts whatsoever sent to any of the pharmacies.
It's a random number generator, I think.
Yeah.
Basically, it's what it is.
Right.
You know, this sounds to me like a great job for a part-time pharmacist. I mean, I'd love to be in a clinic setting right there where you have the prescriber and the patient, and, you know, you can have informal conversations, and, you know, your pharmacist is actually where the decisions are being made.
It's so low-tech, it's high-tech, right? I mean, your doctor, your
Yeah.
pharmacist, and the
How
patient, and
novel.
the nurse.
I mean, the team approach, which is what I learned in pharmacy school in Charleston in 1977, the family practice clinic. I mean, I just have a hard time trying to figure out why you want to not have somebody on site, other than the economics of it.
Yeah, we just can't afford it, and we think,
Well, who's paying for the medication? I mean, who's reimbursing for the prescriptions?
so I guess there's private insurance, there's Medicare and Medicaid, and then about a third of our patients indigent funding. So we get a little bit of money to cover those costs, and the margins just aren't there to.
Well, this
employ-
is what community pharmacists are facing every day. And, I mean, I'm very sympathetic to that argument, but it's very difficult when you're arguing cost versus, you know, safety or lack thereof, or trade-offs. It's a hard argument to make. How extensive is your formulary? How many hundreds of, or dozens of drugs are going to be handled? And how many, Let me ask.
Our inventory is pretty simple. I mean, if you walked into a pharmacy, you'd be like, I mean, we're not your like, typical, probably what a lot of you have in your stores. I mean, like I say, I don't have any reconstituted antibiotics for kids because, you know, we just don't, they don't come into us to get those. They're usually a lot of times one-time prescriptions. You know, our patients are, you know, like elderly or, you know, mental health patients that aren't coming there. They come and get their other, you know, antibiotics with us and stuff like that, so amoxicillin and those type of things, and we have,
What,
but it's
approximately how many line items would you have on the shelf at any one time?
I don't even know.
300, 600?
Probably about 400. I'd say probably maybe even less than that, maybe 350.
How many technicians would be on site at any time?
And at my pharmacy currently,
At the Hillsborough site, the
There'd be one.
proposed one technician?
yeah,
And what are the anticipated operating hours?
probably 8:30 to 5, the same time as our clinic is open, just the same time that the same hours that the clinic is open,
Monday through Friday?
Monday through Friday.
Is there always a physician on there during that time period?
Yes,
That's
there is.
correct.
So if you take a vacation, do you have somebody that fills in?
There's always, yeah, I think there's some billing stipulations. There's always a physician in the clinic.
Some sort of provider, whether it's a nurse practitioner or an MD or something.
Okay, yeah, maybe there are times where there's just a nurse practitioner.
How many patients a day are seen?
In Hillsborough?
Hillsborough?
I think maybe close to 85 to
Patient-
100
Patients a day?
patients a day.
Not all of which I presume would get prescriptions, but that's pretty good sized patient volume.
Yeah, I think, yeah, yeah, I think 85 is a fair number.
In statement 6 of your operation, who is trained pharmacy staff?
Meaning our technician,
Okay.
or, I mean, we only have technicians, we don't have cash register people or anything like that.
In the event of number 7, in the event of telepharmacy system becomes inoperable, that probably should read when, but neither here nor there. It says the operation will cease. What happens if it's down for hours?
Well, like you,
We gonna leave the patient sitting there?
No,
We
I
gonna
mean-
tell them you can't get your stuff?
well, that's right. I mean, that would be a situation where we have to say, well, you know, this time, unfortunately, you know, they might have to go someplace else to get it filled.
And number 8.
But I mean, that happens to anybody, though. I mean, my store, I have a pharmacist there, and I've had times where, you know, we've lost power and,
And number 8, we talk about a custom label at the remote site. What if there's a need for a modified label? Who's gonna modify it?
modified in which way? I'm sorry, what do you mean by that? Like
Well,
modifying how?
if the physician sees the need to change the dose schedule, if the patient is not being compliant, and a lot of us older folk need to be reminded to read the label, because we don't. I have scores of patients that never read a label. Well, my doctor gave me hydrochlorothiazide 14 years ago and said take 1 a day, 12.5 milligrams. And here 14 years later, it's not, well, last month when we fixed it, we changed the label to say 2 a day instead of 1 a day. Well, I don't read the label. They do that all the time. I'm just asking, I'm trying to figure out what's going on over here, you know.
Sure.
Like I say, I'm from Moore County.
The label wouldn't be modified. I mean, it would be like a new prescription would be ran through, you know, so there'd be a brand new label put on it. That
So
pharmacist
the
would check.
technician does have the ability to modify a label?
Right.
Or will you do that and it's
Right, I would.
telepathically sent over and printed.
Right.
I got you. Okay. I just, like I
Yeah.
said, wanting to know.
We'll print the label in Hillsborough.
For the record, I note my surprise and delight that telepathy is now a real thing, so.
Like I say, I'm from the last century in Moore County, so I have trouble with some of this.
Can I ask a clarifying question, Jason, that maybe I could, when you're talking about custom labels, you're not talking about, and see, I'm not sure if this is your question, I'm trying to understand it too. You're not talking about that everything would be pre-labeled. I mean, it would be the creation of a label, just like a creation of a label would happen at the Durham facility or the Southern, or the Pinehurst facility or at Prevo or anywhere else. When you say custom, is my interpretation, just for my edification or clarification, when you say custom, what you're talking about is it's going to have some additional information on it so that folks know there's the Durham, your pharmacy in Durham, that information, that's what you're talking about. You're not talking about pre-labeling.
No, there's no
with sort of these
pre-labeling,
rigid sort of things that, you just have to slap it.
Correct.
Okay.
Yeah, I
That-
mean, it would label.
That may not have been your question, Stan,
Patient's
but I got
name
confused.
and address and
Yeah, I
information
got
would
it.
all print out on it. And then, I mean, the label itself would, meet all the board standards. It would have the, address and telephone number of the Hillsborough office, but we also put in here that we would put an additional sticker on
In other
there.
words, what your label would look like
Correct.
really would be what the labels that are required for centralized prescription, central fill. Our rules presently say if you're operating a central fill, then the labeling must have both the information for the pharmacy that provided the product directly to the patient, as well as the information on the pharmacy that did the central fill operation. So that's what you're talking about,
Yes.
right? Okay, that may not have been your question, but that helps me.
That helps me too.
Yeah.
Mr. President, I have a couple questions. You say you will mirror the hours at the telepharmacy site versus your home office.
Correct.
And are you the only pharmacist there?
Nope, I do have a part-time pharmacist as well that fills in like when I'm not there or my vacations and works. Right now, she only works 8 hours a week.
Do y'all close at any certain time for lunch or?
We do not close at all.
So, and your typical hours are, the Hillsborough office are 8:30 to 5:30?
8:30 to 5, or
Okay.
we're open. Our clinics are open from 8 to 5. The pharmacy's open 8:30 to 5.
Okay. You say you're gonna, if this is approved, that you're gonna do a closed door pharmacy site at the telepharmacy site?
In Hillsborough, yes, sir.
Is that site within the clinic setting?
It is, yes, sir.
Is the only entry into that site through the clinic?
Correct.
Okay.
What we plan on doing is taking actually his office, because it's the biggest office over there, and turning it into a pharmacy, which is pretty much right in the middle of the clinic.
Okay. So patients would have to come through had to be seen at the clinic
Correct.
to get into the pharmacy to have a prescription picked up or
Correct.
filled. You also mentioned that you would only fill prescriptions for the patients of the clinic.
Correct.
Is that family members of the clinic or just patients themselves?
Just patients of the clinic.
Okay. You also mentioned that you would fill any other prescriptions as long as there were patients of the clinic.
Correct.
Well, I would think when you open that door, you're opening a larger inventory required, because I'm sure they see other physicians not only at your practice.
Sure,
So
absolutely.
that your potential for inventory control is gonna get really opened to become in my opinion, not more of a selected pharmacy base, but now you can have everything.
Right, and it's not, you think that it would grow a lot larger, but we found that really a lot of our patients with the medications they're on are pretty much stuck around diabetes, asthma,
Right. CHF.
cholesterol, and blood pressure
Right.
are pretty much probably the 4 next disease states that our patients have or we deal with. Of course, you have your few random outside things, but and that's what we do now in Durham and Pinehurst with our patients as well too. We carry those things. Most of those medications, except for the asthma medications, are mostly generic type stuff at this point. So cost is fairly reduced, although we all know generic prices are going up. But so we do a pretty good job as far as controlling costs. as far as the other medicines that we do carry.
But don't you feel when, I'll go back to one of the examples you get on asthma medication, don't you feel, even though you might have a teleprompt there showing how to use it, Advair or Spiriva, to me, that would be a hard concept to watch over a monitor instead of having it in my hands where I can open it up and show that patient. That's one concern I have on that particular, as far as patient education. The other question is, on controlled drugs, and Mr. Kim, I might get you to weigh on that, is my understanding that a technician cannot fill out a 222 form to order or a CSAUS.
Yeah, they can. Yeah, actually, they can. If a technician holds a power of attorney from
Okay.
the DEA registrant, then yes, they
They
can
can.
operate CSAUS and a DEA
you're
222.
putting that-
In fact, interestingly, federal law doesn't even specifically require that it be anybody licensed at all. It's anybody to whom now, I obviously advise pharmacies, you would do well to make sure it's somebody who's an
Right.
employee of the pharmacy. But a technician could do that with a power of attorney.
So
Or
you-
the janitor,
What's that?
or the janitor.
Under federal law, yeah. And
So-
then everybody can look forward to going to jail.
So your technician, you have that site then would be responsible for ordering controlled drugs,
Correct.
checking them in, stocking and dispensing the, even though you are at another site,
Correct.
verifying that, you're putting that responsibility on that technician to do
Correct.
that. Okay.
That's why we feel too, I mean, of course, finding the right person, I think, is gonna be one of the big issues as well too, that finding that person that has, I think I put in here at least 5 years of experience and is, right, I'm gonna have a lot of trust in that person. We're gonna have to have a lot of trust in that person over there. Thing is though, like I say, it's inside the clinic, so it's not like she's just operating, or the person is just operating, randomly in some storefront someplace. They're gonna be inside the clinic, and then, of course, hopefully with the quality assurance stuff, that we won't have any issues.
Well, one of my concerns is you're putting a lot of responsibility on a technician, not only to check, fill, run through the computer, answer insurance questions or insurance problems, and then gonna have to ring that patient up. And then you're putting to me, a lot of pressure on yourself, because you're already fulfilling that job that is required by you at your resident site.
Right.
Now you're trying to balance both of those, which, from a time standpoint, I'm trying to get my hands around that. Our job is public safety.
Sure.
And are we compromising that to save a pharmacist's role at the remote site? I understand the concept, but that concept is coming, is here, I understand that, but our goal is patient safety and getting that done. So that's all I have, Mr. President.
And I have a couple. Thank you.
Yes, sir.
So your clinic, your satellite clinic is gonna fill prescriptions from anybody that they present as long as the clinic patient, is that right?
Correct.
So if they come in with an oral reconstituted antibiotic, what are you gonna tell them? You say you don't stock those.
Right. I mean, we would have to say, like we do now when they bring it into our derm clinic, is that we tell them that we don't have the medication in stock, we can order it for tomorrow. Or if they want to wait and bring it back the next day. Or, if they want to wait till the next day to get it, or they can bring it to another pharmacy. I mean, do you have all the medications in your store and every prescription that comes in?
I don't specifically try not to have some of them.
Okay. I mean, we're not specifically trying to either, but we just don't.
Well, I mean, you said
have it
yourself,
because
Jason,
we
that
don't-
you limited to what you, and I understand, I'm
Right,
just
because
trying.
we've never had anyone bring anyone into us either, though. I've never had anybody bring in a reconstituted antibiotic prescription to me for a kid for an antibiotic.
Okay.
And just to make the point, I mean, primarily a mental health pharmacy, and some patients get,
I would tell you that mental health patients also have other needs.
well, they do,
Okay, yeah.
and some get all.
I'm
their-
just trying to get clarification. I'm not being critical. I'm just trying to get clarification. No, go ahead. I didn't mean to interrupt you. Excuse me.
No, I just wanted the bulk of our pharmacy business is mental health. We do feel some patients want all of their meds filled at our clinic, and I'd say probably a third continue to get their general medical prescriptions filled at an outside pharmacy, at the Duke Pharmacy where they get their medical care, or I don't know if UNC Pharmacy has a pharmacy or not, but some of our patients continue to get their medical prescriptions filled at outside pharmacies.
And your nurse who's taken histories rely upon the patient to tell them all that they're getting from outside pharmacies.
And we ask our patients to bring their medicine, all their medicine bottles. That's the best way.
So there's no way of verifying whether they're telling the whole story or not. Of course, there's none in my drugstore either.
Right. We think
I'm just
we
curious.
think the bottles are a good way.
Right.
Okay, and a couple more questions.
Sure.
If you get prescriptions from outside physicians, they will not necessarily all be electronic, is that right?
Correct. I mean,
'Cause
not everyone.
pretty much you said you were going to all electronic model, but that really,
I meant in our clinics.
okay. So at some point in time, that you'll be relying on other pharmacies in Hillsborough to fill some prescriptions for these patients, is that right?
If that's where they go, then I'm sure that will happen, yes.
Well, there are pharmacies in Hillsborough, right?
Yes.
Yeah, okay, so,
I'll stipulate to that.
yeah, I looked them up too, thank you. And as Joey said, Mr. McLaughlin, you're comfortable with the technician role or whoever of handling all controlled drugs at that site, is that right?
Am I comfortable with it?
Yeah. You'll need to be because you're the pharmacist manager,
Yes.
so you're
Because
responsible.
it all falls back on me, yes,
Yeah, it will,
yes.
definitely, okay. How do you plan to assess this pilot program?
And as far as the outcomes of it,
Well, pilot program, typically we say, well, this is the pilot. My next question was, what's your time frame? But it kind of all goes together. How do you plan to assess it?
sure. Well, basically, we want to look at just adherence with our patients, just to look at a patient and say, well, here's a person in Hillsborough that we found that wasn't adherent, and that we're making, seeing a change in them. Are they utilizing outside? Have they been readmitted to the hospital? Like they were before, were they utilizing outside resources previously that they're not doing that anymore? Those type of things, the same type of stuff that I think that we do in Durham.
Do you have a time frame in mind?
For opening the pharmacy and doing this?
Yeah.
Is that what you mean? Yeah, I mean, once we get the approval, I guess it just takes time to, get permits and get numbers and get everything that we would like to hopefully be up and running sometime in the fall, before the end of the year.
I'm talking about a time frame when you plan to assess.
Oh, I'm sorry. I thought, yeah, I think after a 1-year time frame, looking and saying.
So
if-
you're
once
asking
the
for a
pharmacy-
1-year pilot project, is that right?
That seems,
Yes.
Yeah.
And going forward, if
Yes,
this,
no, or-
yes.
Yes, okay.
What we really would like to do, and the ultimate goal here, is to, if this does work and it is successful, which we feel like it will be, is to petition for a rule change and make this something permanent, so it's not always a waiver of enforcement, that it actually something that's in the rules, the board rules, that allows us to do this.
So you answered my next question already. You anticipate with the culmination of this pilot project, if you categorize it as a success, then you'll be asking the Board of Pharmacy to make a rule change to allow telepharmacy to continue, is that right?
Correct.
Okay. And that would not be just limited, that would be, I think that's a great idea. As a business owner, if I knew today that in 12 to 15 months, I could have a headquarters with a bunch of high-tech stuff going on with 5 pharmacists sitting there, and I could run all my pharmacies throughout the state with no pharmacists in there, I could probably make a lot more money. I don't know about the patients, but, so the success of the pilot project to you is better patient adherence, is that right?
Better patient adherence, better patient outcomes,
Better
reduction of overall healthcare dollars,
Say that again?
better adherence, better outcomes, better use of healthcare dollars.
How are you gonna document that?
Well, I can't really document that per se, but I mean, just looking and saying, here's a patient who may have been admitted to a state facility 3 or 4 times in the past year due to non-adherence, and now hasn't been to a state facility at all this past year, I would say, and they were been using our pharmacy, then I would say that was a success, and we had cut down on healthcare dollars in that way.
Okay, thank you.
Can I ask Jay a question?
Certainly.
Jay, when I was on the board before, like I mentioned earlier, there's a great problem with technicians and stealing drugs and selling controlled substances and all that kind of stuff. Did we stiffen the laws in any way for technicians handling drugs as it relates to?
To controlled substances?
Yeah, or non-control. As I remember, either you or Dave Work, and I believe it was Dave, said that there were more actual deaths from non-controlled drugs than there were controlled.
I think there are a couple. Let me try to untangle. I think there are a couple of things. We have that. The law says that if a pharmacy knows or has reason to know or suspects that a dispensed drug contributed to the death of a patient, it's required to be reported. The largest category of death reports from that is anticoagulants. It's not controlled substances. Now, I want to give a very significant disclaimer. There are, in my opinion, absolutely no scientifically or statistically valid conclusions that can be drawn from that reporting system, because it is a reporting system. We don't know whatever deaths that might happen, and pharmacists don't have a reason to know about it. So it I guess serves some canary in the coal mine function, but I wouldn't extrapolate it beyond that. But it tends to be anticoagulants. It's the largest single category that's reported to us, and mostly from hospitals, which makes sense, right? If a patient comes in, you know, the classic case, Stan, is a patient comes in, they've had a stroke, they're administered TPA, and they bleed out. Well, everybody knows there was at least a temporal relationship. So I don't know what to do with that data except say that it exists. With respect to handling drugs, I mean, no, I mean, there's technicians, as you well know from your own practice, handle all types of drugs.
Absolutely.
Soup to nuts on that.
So if they're walking off with particular drugs, doesn't matter what kind, until somebody catches them, there's not much that can happen. And even then, the Board of Pharmacy has very little as to what can happen. It has to go to a local law enforcement agency.
Well, so diversion gets detected in a number of ways.
Yeah.
Obviously, one, it depends on what the particular inventory system is. General vision, of course, a pharmacist manager is responsible for the security.
But all we can do is take their certification away.
Yes, as a legal jurisdiction matter, all that a board of pharmacy can do for a pharmacist, for a pharmacy, for a technician is revoke, suspend, condition.
And for a pharmacist, that's significant. For a technician, it's nothing.
I wouldn't paint with that broad a brush. I think that there are category, well, and this is true for pharmacists as well, over the Venn diagram would look a little bit different. For career technicians, certified technicians and the like, they've got skin in the game. They do have a lot to lose by doing that. The high school kid or the 21-year-old who's not in college, who's just doing this part-time, they don't have as much skin in the game.
Help me again. Like I say, I've been out of the loop here for a while. The average salary for a certified technician in North Carolina is what, 15, 16, 17 bucks?
I have no idea what that is. I'm not sandbagging it. I don't know.
Yeah,
and it varies quite a bit depending on practice.
I know we hadn't got there yet, but they want $15 an hour now to turn hamburgers, you know.
I have no comment on that.
I know you don't. I can know. I'm just trying to understand.
Right.
So significantly, we haven't changed the rules for technicians and what we can do with them in any way. We have to rely on local law enforcement.
Oh, you mean for punishment?
Yeah.
Right. I mean, that is and always has been a law enforcement function. I mean, when you talk about punishment beyond removal of a credential, which is, of course, a punishment, yeah, you're talking about imprisonment, criminal charges, and the like.
Well, all
Right,
I'm
it's
saying
only
is,
law enforcement.
all we can do is remove the credential and depend on somebody else to do something else with it.
That's correct.
Okay.
That goes beyond us. And what we generally do is refer these
I
cases
guess the
to law
question is, because I want us all to realize the seriousness of what we're talking about here with a technician doing a pharmacist's job. And to me, that's a serious matter.
Any other questions from the board members?
First of all, you do like 150 prescriptions at the Durham,
On
approximately,
average, about 100, yeah.
and you're expecting to do how many in the Hillsborough?
We were looking at about 40 to 50.
Okay. So do you feel like that 150 prescriptions a day is pretty busy, or?
It's actually not too bad. We normally, like on Mondays, we're filling about 250 on Mondays, and then each day it kind of gets a little slower. Mondays are when we have most of our providers there. And then, like I said, by the end of the week, by Friday, we're only filling probably about 60 prescriptions on Fridays because we only have one provider there in the Durham clinic. on Friday.
My question to you is, do you really think you can adequately treat the patients in Hillsborough as they deserve if you're over here trying to wrestle with 250 prescriptions a day?
I think I can, yes,
You really do.
yes.
My experience with these patients, and I've worked for a company, I worked for about 5 years with patients with mental issues. They have a lot of questions, and because they take a lot of drugs, and but they have almost more questions than other patients, and their situations are so dire that I feel like they need a pharmacist face-to-face intervention even more than your average customer, perhaps, because of the number of drugs, because of the depth of their disease and illness. One thing that you guys mentioned was that North Dakota's been doing this and all this, for years and everything. And but North Carolina, we're talking about today, is a lot more densely populated, and so we have a lot more pharmacies, and so we don't have that problem. I understand why North Dakota does it, and it makes sense. But North Carolina, we don't have that problem, and we don't have a lack of pharmacists. We've got lots of pharmacists, and how many reciprocate every month? Something like 40 every month, every single month. And we've got a new pharmacy school going online in 16. So to me, there's not a lack of pharmacists. I don't really see anything but the money, and that you want to not have a pharmacist because of the money. But you're a private institution,
We are,
okay? So you work for profit,
we do.
okay? And you can pay doctors and nurses and technicians and one pharmacist and do all these other things that you told us about in March, all that they're being paid for. But you can't afford one more pharmacist.
Well, I think that certainly, I guess, addresses the business side, but clinically, this is about access, right? My patients show up when they need something. And what they need in Hillsborough is pharmacy services. They don't go to their community pharmacies. Community pharmacies do not get the prescribing of clozapine correct. I need to get the patient's lab. I need to talk to a pharmacist who understands the monitoring process, and I need to talk to that pharmacist who knows the patient. We're one of the few practices that uses clozapine on a regular basis. Long-acting injectable meds. I need to have what the patient needs stocked in-house, so that when I change the dose of a long-acting injectable med, the patient doesn't have to go to an outside pharmacy, come back to the clinic, because they won't. So this is about access and how we can prevent human tragedy, right? I mean, a good dose of a good medicine goes a long way in mental health. And we put pharmacies in our two big clinics to improve the quality of patient care. And I feel like our patients in Hillsborough aren't getting that. And I want to keep pharmacy services in the loop. And I think this is a reasonable way to do that. We are a for-profit corporation. It is for very little profit. I mean, all these great ideas of mine cost an extraordinary amount of money. I'll get no opportunities to speak at the business school, I can promise you that. We're just trying to do for our Hillsborough guys what we're doing in Durham, in Pinehurst, and I think this is a system that will work. I mean, I do think we need to address the quality control issues. I mean, we do need to measure whether or not controlled substances are staying in the pharmacy or not staying in the pharmacy. And I think we'll have that answer in a year.
I agree with all that. I agree with everything you just said, which repeatedly tells me that you need a live, in-person pharmacist in Hillsborough for those patients. They deserve the same treatment that the other patients are getting. And to me, I think this is more of a business dilemma than a dilemma for us. And state and federal laws, as far as I know, do not allow technicians to dispense. And that's what you're asking us to approve, correct?
No, I mean, because the pharmacist would still be involved as far as the final verification, so.
What's going to go on outside that picture? They're going to take a picture for you. What's going on this side? What's going on this side? What if they have 3 patients at one time and they're just putting things in bags? And it can get very confusing very fast with one person. And I strongly feel like these patients deserve, I'll use that word again, deserve a face-to-face encounter with a pharmacist every time they get their prescriptions filled and the pharmacist dispenses them. Otherwise, you're going to have some problems with Medicare, Medicaid paying for these patients need a pharmacist, in my opinion.
I have one question. On the, I notice you have here that you would do a monthly check and inventory at the off-site. Is your on-site pharmacy you have, do you do it just once a month? Do you do daily checks on your inventory?
At the pharmacies now?
Yes.
We don't do any kind of daily
Don't
checks
do
or
any
anything
checks.
like that, no.
Okay. All right. Thank you.
Any other questions from the board? Mr. Campbell, would you lay out what our options are at this point,
Yep,
please?
I will play them out. Your options would be,
Is one of those a bathroom break?
yeah, I was gonna suggest that after this business item. That's all right. The options on the table would be that the board could say, we've reviewed this and we approve your pilot project to go through as stated in this plan.
Which is open-ended at this point, it appears.
Right.
I don't see any timeline other than,
Your second option would be to say, here are some specific things that we would like to see addressed in the plan, and to do those specific things and bring it back. But you do need to say, what are they? Not just, we don't like it, come back. You say what the specific things are. Or you could vote to deny the pilot project and say, we don't think that the project fits the criteria that are laid out in Rule 2510, and state why that is. So those would be the options.
Is it appropriate for us to have a closed session to discuss that among ourselves or not?
That would not be a basis for a closed session under the Public Meetings Act.
Okay, thank
This debate needs to happen in the sunshine.
Okay.
We don't have any precedents of pilot projects like this in the past, do we?
No. What I would say the closest analog to this is remote medication order entry. That would be the closest. Well, they may not. Yeah, I think that's still close, which of course we have, that's allowed by rule, and the board is, and in fact, the board revised, you remember, Stan, we revised those rules fairly significantly. But no, there's never been the last large true pilot project, well, the last two pilot projects we had, one was a remote medication order entry pilot project. I can't remember if it happened before or after you went off the last one. I think it was before. But we had the folks in Tarboro, whose names I can't remember now, but remember, they piloted some home office-based remote medication order entry. And they piloted that for, I forget what it was, like a year or 2 years. And that was used to inform the revisions that were ultimately made to the remote medication order entry rule to allow some off-site based RMOE with certain criteria. So that would be an analog, closest analog. And then the last pilot project, significant pilot project before that, were the Broughton State Hospital project, which you remember very well.
I do remember that.
And the Baptist Health project, which you remember very well.
Oh, yeah.
And I also remember when the Broughton project was granted, that little bit later Baptist wanted to talk about a similar thing, and that one was denied.
No, theirs was granted.
Was Baptist granted
Yes.
too?
Both of those pilot projects went forward. There was one other inquiry during that, a very preliminary inquiry that came from Pitt. And it wasn't denied. They decided I mean, I don't know. You're asking me to get inside. They never came back with a formal proposal. They were invited to come back with a formal proposal. They never did. I don't
Okay,
know why.
that's
I
what-
think the calculus was, we don't need to reinvent the wheel that Baptist is
Yeah,
already rolling on.
thank you for clearing my memory. It's been a long time.
I'm telling you, mine ain't as clear as it used to be, but.
So
I have one
the three
question.
options.
One question for the physician while we're talking about that. Does the medical board allow you to treat a patient teleconference? Can you, like, if I wanted to see you but I couldn't come to you, could we get hooked up on the video and you could treat me like that?
That's acceptable to the medical
Yeah, the
board.
answer to that is yes.
So,
So you could prescribe medication, you do whatever you want to, and never see me, is that right?
I mean, ideally, I'd like to see you in person.
Oh, you would, okay.
I would, but, you know, a lot of times it's the difference between delivering care or delivering no care. And so we do use telepsychiatry.
But ideally, you'd like to see me in person, is that right? Yeah. Mr. President, I would suggest just my own personal 1 out of 6 perspective. We've got a lot of information here that we need to digest a bit. I don't think it's incumbent upon us today we have to make a decision on this proposal. We can certainly put it on another agenda. We've got the information, we're probably not gonna forget that. I don't know how the rest of the board feels about it, but I feel like that the more I think about it, the better decision I would make.
That is certainly an option that's available to the board, is to take it under consideration. What I would advise the board is that if there is any additional specific information or tweaks to the proposal that you might like to see, that you communicate those today. So it doesn't become a can kicking exercise with that.
Mr.
Did you have
President?
other questions?
I have, if you do that, I have several questions that I'd like to have specifically added to the proposal. One of those is the time frame I asked about. How you choose to assess the success of this and what that's based upon. And I'm not sure I understand, what is the goal here? Why do you want to do the telepharmacy in Hillsborough in a psychiatric setting? Better patient adherence and compliance, is that right?
To improve patient adherence, compliance, and outcomes, and to involve pharmacy services in a place that they're not currently available. So just like as we talked about, doctors can see patients remotely. I think there's a role for pharmacists to do the same.
Mr. Minton, can you put that into a motion?
I don't know this,
I got a question. Mr. Minton, you're asking for a guideline to when you're gonna analyze what the data produces, what you're asking?
I mean, a pilot program, to me, is a program to determine if this is a good idea, if it works. If you don't know what works means, then you won't know if it works or not, number one. And you gotta have a time frame, because after a pilot project as this, we're gonna be called upon to do rulemaking based on the outcome of the pilot project. The rulemaking will apply throughout the profession of pharmacy in North Carolina as we now know it. I think that this,
Okay. Mr. Campbell,
Yes, sir.
on the feedback, based on what the board decides today, do you put a timeline on the pilot program? We will do this for 6 months, 9 months, 12 months, and come back and review data? 'Cause I know when we did the Broughton, we
Yeah.
actually went on site to review.
Yeah, a couple of things on that. There was, for those projects, part of the plan was that there was going to be a periodic report to the board. And I can't remember now exactly what that was, if it was
Seems like
6
it's
months.
quarterly, Jay.
What, yeah, and you maybe, I just don't remember what it
One at
was.
Broughton, I'm not sure, but I think it's quarterly.
But there was a report, there was a set of data that they would report back to the board every so often. And that could certainly be a part, I mean, if that's one thing that you would like to see in a pilot project proposal, because the rule does specifically state with respect to pilots, that is subject to continuing compliance with the conditions approved by the board. If part of carrying out your appropriate oversight of compliance with those conditions would be, Jason's group says, here's what we're gonna monitor, whatever that is, and I'm not saying what is, just to give a hypothetical, that number of errors, or if there's a compliance metric, or whatever it is, I don't know what they are. That's it.
And-
That you would say, we'll get a report back to that every so often. Quarterly seems like not a lot of time or not a lot of data from one small site. But that could be part of what you would like to see in a proposal, is what are the metrics, the public health and safety driven metrics that you would like to see, and whatever that.
And Jay, I think, if my memory serves me right, before we approved the pilot project at Broughton, the board actually went and did a field study.
That's correct. We did it, there was a field visit to Broughton to take a look at their process. And, because I remember you went, I don't know if it was the whole board, but it was most of the board.
Yeah.
Joey
Most of-
went,
yeah.
Betty went.
Yeah.
But yeah, that could be another thing. And now, these guys had to figure out, of course, what you run into. Again, Jason can fight his own battles on this, is, do you spend all the money to set up the system for the board to come over and look at it and decide whether they should have the system? I mean, I'm not much of a businessman, but I probably
Yeah, I
would have concerns about that.
I understand.
I'd just like to keep my office until we know for sure.
Well, there ought to be a site somewhere not too far away, that you could see the software, the technology in action.
I mean, the person, they wanted to come with me, and I told them that I wanted to come on my own to begin with, but if you would like to have the telepharmacy people come and demonstrate the software, and they've been to many boards of pharmacy to do this presentation, have helped boards write the rules and different things like that, that they were more than willing to come and actually very anxious to come. But I didn't want to throw that on you guys as well either, until we kind of knew what direction we were going, and if this is something that the board is in favor of going towards, but does have questions and concerns, and they, want me to come back with something else. Then when I come back, I can come back with them. They have a beautiful PowerPoint presentation that they tell me that they would love to show you, and demonstrate to you the system and how it works and everything like that. But I kind of suggested to them that at this point in time that I didn't think it was appropriate for them to come until, the board was even open to the idea of doing this.
We need to see that at some point in time.
Absolutely.
I'm gonna call for a 5-minute emergency break. I would encourage the board members not to have sidebar conversations outside this room because that would violate this Open Meetings Act rule.
Yep.
Be back here at, well, let's say 5 minutes till 11. I had meant to take a break a long time ago, but it just didn't work out.
That's been good discussion, Mr. President.
We've had extensive discussion about this.
There you go. We're filling
Proposal.
prescriptions from telemedicine physicians now.
We need to come up with some action.
Mr. President, I would like to make a motion to deny this waiver for this proposal at this time.
Do we have any discussion on that motion? We ready for a vote?
We don't have a second.
I don't think you can have discussion or a vote if you have a second.
Second?
I second it for consideration of the further discussion, I guess.
Further discussion? Is that what you said?
Yeah, you can't discuss it till you have a second.
Thank you.
So we have a second.
And I did second.
Thank you. Any further discussion? All in favor of the motion to deny the,
Could you state the motion?
the motion is to deny the request for a pilot project.
Just straight out deny it?
Deny it.
Okay.
All in favor?
Aye.
Can I see a raise? 2, 3. All opposed? 2.
Wait a minute, I'm not sure what can I see that again?
The vote was to deny the motion, and I saw 3 hands go
Okay,
up.
the 3 hands, Stan, Robert, Carol, and then opposition or the 2, okay?
Motion carries.
Yeah, it does. Thank you, Jason.
Thank
for
you.
coming in. Board members, next item on the agenda is Chris Cialco is here from Pipeline RX, and she is here to request a petition to amend Rule 1417 concerning remote medication order entry. By way of background, Chris has a presentation which you have seen. Board Rule 1417 governs remote medication order entry, and as it stands, Rule 1417 sets forth the requirements under which healthcare facility pharmacies that are not open 24 hours a day, 7 days a week, may contract for the provision of remote medication order processing services when no pharmacist is present. As I've noted in the background, the board staff gets frequent inquiries concerning the use of RMOE as a supplement to on-site pharmacy services, and Pipeline is petitioning the board to amend 1417 to allow that. As I noticed in your background, referenced in your background materials, Mr. Pinion did provide a very concise explanation of the petition for rule amendment process, which I trust you all have read, and we can answer questions about that. But in the meantime then, Chris, I'll turn it over to you to make your presentation.
Thank you. Oh, great. I was going to say, hopefully it's not too late in the morning.
Stay away.
I will be very short and concise. Please feel free to ask me any questions, but since I have not been, I usually do the board presentations. I am a pharmacist and one of the founders of Pipeline. I thought it would be great to give you a little bit of an overview of where we are based on the approval that we've gotten from the board and the clients that we're servicing currently in the state. So this is, it'll be a quick overview, the current requirements, what we are asking for a proposed rule change, and the rationale for it. Pipeline, we were founded in Q4 of 2009. We have over 200 clients across the United States. Corporate headquarters are in San Francisco and Chicago, so we split the country in half. State board approved to operate in 35 states. We are active in 25. We have North Carolina licenses, both in good standing for Illinois non-resident and North Carolina resident license. We currently have hospital clients that range from critical access hospitals that are 15 beds to university teaching institutions. We cover over 9,500 beds. Clinically, we have verified over 5.1 million med orders, and obviously that grows daily, as well as the number of clients that we service. Just for your information, all of our pharmacists are clinical pharmacists. The majority of them have a PGY1 or PGY2 type of training. on average, and I'll give you a little bit of an overview, but they are our employees, they are not contracted. So clearly, we evaluate them very stringently relative to their activity. So our real goal, very simply from a remote medication order processing perspective, that is all we do for a living, is that we mirror the exact cognitive and clinical roles of the client hospitals on site. So I would tell you we are very proud of the fact that the nurses who are really our clients, if you would, don't know that we're not on site many times. They have a direct line to us, to their pharmacy team, and it's always the same people. This is not a room full of people pulling down orders, so they know that Chris is on Monday, Tuesday, Wednesday, Thursday, and John is on Friday, Saturday, Sunday, for example. We execute with the client intimacy, and let me give you a little bit of insight. The requirement is that we must pick up by the second ring if the nurse is to call, and the calls vary. I've never given this med before. What am I looking for relative to side effects? Could you help me go through this calculation? I've got 2 IV lines run and I'm worried about cloudiness. So the questions are multiple. Now with the uptick in hospitalists, both employed and rented, we also get a lot of calls from physicians on that dedicated line per the client, and they know who's on the other line. And then we verify every single order. It's not entry, okay? You're looking at the order for clinical appropriateness. In some cases, you are entering it because it came through as a fax or a scan, but with the growth of physician order entry, you are in essence verifying orders. Okay, makes sense to everybody? Any questions? Yes, sir? No? Okay. Now, just quickly, I wanted for you to have insight to the profile pharmacists that we employ. Their goal is the safety of the patient. Overall, that is our overarching goal. And there is a rigorous screening. A lot of folks want to do this. This is a very nice position to have. So our hire ratio to applicants is 3 out of every 100 applicants. They must have a minimum of 3 to 4 years of hospital experience. We're averaging 7. They must know multiple hospital systems. And let me explain that. The pharmacy information system in an acute care setting is a living, breathing, some people say beast. It's an animal that continually changes and is being tweaked and upgraded. So these folks have to be IT savvy. They go through 3 phone interviews, and the reason is, as pharmacists, not only do we have to be articulate, but we have to be very good listeners, because there's always a question behind the question. And then they go through 3 professional reference checks, ongoing quarterly review of their licensure, OAG, and state checks. Before they even come on, they take a clinical competency assessment with a minimum score of 95 out of 100. And it's beefed up with oncology and pediatrics. I am not a ped pharmacist, but when I do pediatrics, I do it 3 times, just to make sure that it's correct. So they go through a clinical assessment. They also go through an IT assessment. And then all the drug testing, national background checks, we do all that as well. They are trained in the client-specific policies and procedures. What is Q6? What's Q8? How do you want the Vanco dosed? Etc. And then also HIPAA and our policies and procedures.
Ma'am, would you say they're trained according to every client they serve, so they know their policies and procedures?
They
for every
must.
client? Okay.
Because the goal, sir,
I understand.
is that there is never a redo. So when the pharmacist comes up, say we're on during the 3rd shift, it's a clean queue. So just so you know, from a clinical quality perspective, and I'll give you a little bit of a feel for the metrics, but the clinical recommendations is we have active consultations with physicians as well as nurses based on a dedicated line per client. We do auto sub and therapeutic sub. Clinical initiatives, antibiotic stewardship has become a huge one. For instance, the state of California has mandated that by July 1st, every single hospital in the state of California must have an antibiotic stewardship program. So that's really grown. And then with MRSA and everything else that's going on, the stewardships are really a big deal. Duplicate therapy. Joint Commission is very focused on duplicate therapy. Q4 to 6, what's the need? So clearly clients have specific programs that they are focused in on, and then the IV to PO. We must have access to the patient labs and all the patient data in order to make those clinical assessments. So clearly we're reviewing all the labs, allergy and dosing. And then we have clients that have specialty needs. We have behavioral health hospitals. You know, you have a tiny little nurse who's trying to wrestle down a 280-pound patient. She needs to get into that drawer and have our meds approved quickly. Oncology. For Bellevue Hospital, for example, New York City, we reviewed all their oncology protocols because we have oncology specialists. There is seamless handoffs. Just to give you a little bit of insight, it's very similar to nursing report. So we come on to a site, we'll call up and we'll say, I apologize, sir. Robert, it's Chris, I'm checking in. What do I need to know? And then you do a download. We got slammed in ED. We've got 4 patients. I've been trying to get a hold of Dr. Smith. We need to change the Vanco dose. So I say, okay, just tell me what my priorities are. I'm on it. And it's really about patient continuity, make sure that we know what's going on from a patient perspective. And then when we sign off from a shift, whatever the length of the shift is, they vary from 2 hours to 12 hours to 24 hours. We also do the report back, but send in a fax sheet, like a logout sheet with everything detailed that the next pharmacist needs to know about. So it's very similar to nursing report, but it's really focused on the whole patient continuity with the meds.
Is that an electronic process?
It's both phone, it must be electronically sent into the pharmacy. So they'll get a fax with the specific logout sheet, and then we have to talk to the pharmacist on the other end. So we go through the sheet with them also verbally.
Would there be a transition from telepharmacist to telepharmacist?
Always. If there are 2 people taking over, that happens from our end. But I'm just talking about the client perspective. But on our end, there is always a transition. Now, measurable quality, how do we assess? It is very important that our clients also know what we're doing. And we measure everything. Everything is measured and time-stamped. So everything is based on the order per shift, and the performance indicators will number of orders that we entered and clinically verified, how long it took, what our turnaround time is. That is critical because all the stats have to bubble to the top. And if there are problem orders, the director of pharmacy needs to know what those issues are. Number and type of clinical interventions. We have an agreement with Quantify. And for those of you who are not familiar, and I didn't share this in the report, but the reports are very detailed. So dose too high, dose too low, lab required, lab recommended. For instance, we do INR recommendations. So they're very detailed so that on a monthly or daily basis, the director of pharmacy knows exactly what clinical interventions we're doing. Question? And then the number and type of calls. They also need to know what kind of calls we're getting because maybe there's a need for an in-service. We do weekly and monthly check-ins, whatever the client desires. And all of these reports that you see at the top, as well as custom reports, are also available to the client. They have a portal that they can go into. So I sit down at my desk, I walked in, I'm the director of pharmacy, I want to know how many orders they did. I have my own specific portal into Pipeline so I can pull all of this data down on an ongoing basis. So, now to the meat. This is the current rule for medication order processing services. I highlighted in blue what we really would like to address, and that is that healthcare facility pharmacies that are not open 24 hours, 7 days a week, because we have a number of folks that are very interested in this service that are open 24/7. And let me explain why. Pharmacies, specifically in the acute care setting, we are being asked to do more with less and are not getting compensated for it in many ways. The first one, and I would tell you, is peak workload times. Patients head up from OR up to the units. Pharmacy is slammed. And that's where you see, and it's very difficult to staff for those peaks of activity. So we have many clients that utilize us during the day for those peak hours. So say it would be from 10 a.m. to 1 p.m., where we are helping the on-site folks do order verification. So peak low work times, quality initiative and patient initiatives, MedRecon. We've talked a lot about it today, the brown bag. We don't get paid for doing MedRecon. But it would be great to have a pharmacist, not a nurse, doing the medication reconciliation with the patient and going through the vials and everything else they're on. And in many cases, you've probably seen it as well as I have, one vial will contain 5, 6 different meds. So what we're seeing is our clients are trying to get into all these other services, but there's just not the folks to do it. They can't bring on extra FTEs. So they've come to us and said, we'd like you to come on for these few hours for a peak workload, because these are the types of initiatives we want to do. We want an anti-coag clinic, post-discharge counseling to prevent readmit, because you know as well as I do, Medicare doesn't pay under 30 days if the patient's readmitted under the same disease state. So the hospital takes the hit. So the programs currently based on the Affordable Care Act are need to grow to ameliorate some of these issues. And your constituents, directors of pharmacy, need help. So they're asking at a 24/7 pharmacy, could we come on for a few hours to help during the day or second shift to do order verification? But the rule as it reads now does not allow us to do that. And I think Jay knows this, and hopefully you've all heard a little bit about us. We are very collaborative with all the state boards. We are very upfront. You know, we provide maybe more information than we should or that you want to know, but we want you to know about what we're doing. So clearly, this is the rule. We've got clients who are interested, so we are asking for the rule to be revised to read, to set out requirements under which a healthcare facility may contract for the provision of remote. Just remove the 24/7 qualifier. Thank you. Was that concise enough?
That's very concise.
Any questions?
Ma'am, do you have any facilities that utilize your services and don't have an in-house pharmacist at all?
Yes, we do. Northern Surrey, and I have the bed size I can give you a feel for. Our current clients currently in North Carolina are Northern Hospital of Surrey County. They're a 100-bed hospital. We service them on third shift. We are their pharmacy on third shift.
Just third shift?
Yes.
Right. Your question is
That's not my question.
Yeah, your question was complete replacement.
Yeah.
And in North Carolina, which shouldn't be the case because that's prohibited by rule.
I'm not talking about just North Carolina.
Right.
Oh, that we provide 24/7 services?
Yes, ma'am.
Only on the weekends. There are some critical access hospitals that we provide service on Saturday and Sunday, 24 hours.
Would it not be possible for a facility with the rule as you have indicated to be done to just outsource all of their pharmacy services?
Remote medication order verification, yes.
All that stuff?
Yes.
Right? Every bit of it?
That would be possible.
Does any of your clients do that?
Yes.
Actually, let me step in on that just so everybody knows what the rule says.
Okay.
Instead of taking shots at it here. Paragraph J in our rule says, nothing in this rule shall be construed to relieve a healthcare facility pharmacy of the need to provide on-site pharmacy services required by licensure as specified in the Pharmacy Practice Act, the rules promulgated thereunder. So our rules do not allow a hospital facility to say 24/7, 365.
So specifically the change that you're asking for then is for a facility that does have 7 days, 24 hours a day to use you sometimes when they do have their staff in place also, according to a contract agreement with you, is that right?
Correct. To give you an example, Caramont is 24/7. They are currently going through an Epic conversion. And for those of you who may be familiar, that's a bear to go through. That we're talking a 24-month process. They're very large facilities. So The request was, we would love to have you come on to help us during the day as we move some folks into providing for the Epic conversion. And we basically said, we can't do that. It's against the rules for the state. The goal really is to help the existing pharmacy to provide other services. We can do the verification. The pharmacy doesn't go away. This is an opportunity to do other services or other needs, be it a Epic conversion, in this case, to an anti-coag clinic, to an asthma clinic, to MedRecon, post-discharge. I mean, the list is pretty long.
Staff meetings, presumably, or extended training.
Right? It could be any number of reasons.
How many other companies are providing this type of service?
Well, we have one national competitor, I would tell you. And then there are some very small localized providers, but we are a national company.
I'm just thinking if we made this rule change, I mean, obviously, your company does a very good job,
Thank you.
but what about the rest of them? I mean, you're paving the way, and others typically could, or obviously could follow.
Well, and that's why, truthfully, we like to have collaborative relationships with the state board. We really think that just somebody shouldn't be able to set this up, because there are HIPAA requirements, there are all kinds of requirements as it relates to IT. The certification of the pharmacist is absolutely critical.
So if you set this service up in my hospital in Hickory, North Carolina, where would your pharmacist be physically located?
North Carolina. We have a call center in North Carolina.
Okay.
Mr. Campbell, does staff have any recommendation on this request? Is that appropriate?
We don't have a recommendation one way or the other. The options that are available to the board under this process is you can, and Clint can step in and correct me when I mistake.
Good memo.
You can, and it keeps them busy, that's for sure. The board could go ahead and publish the proposed rulemaking for notice and comment and go through the notice and comment process. And that, as you all well know, going through notice and comment does not obligate you to change a rule, but it's a method of gathering information. That would be one option. Second option would be if there is specific information that you don't think you have, that you would want to have before making a decision on whether to publish for notice and comment, go about the process of gathering that information. You can decide not to make an affirmative action, not to go forward with a rulemaking, but you do need to give a specific reason for that. It is a final agency action, and you have 120 days. The 120-day period during which you are required to make a decision runs through September 30th. So we will have at least 2 board meetings between now and that date, and could convene another one if we needed to. So that's really what's on the table. The only thing I will say, and I'm not taking an advocacy position, it's not my job, that's y'all's job, or Chris's job, is board staff get a lot of inquiries about having this as a supplemental option, not as a replacement, as a supplemental option. And take that for what it's worth. But it's really totally up to y'all what you want to do. I mean, going through the notice and comment process, there's not any downside to it, really. I mean, that's how we provide notice and gather comments. So.
It's very difficult for a director of pharmacy to hire someone for 2 to 3 hours. It's tough. Also, they don't have the budget to do it in many cases, to bring on a full FTE. So this provides a very, very nice alternative.
A lot of the staff inquiries did come in during the different Epic conversions. Caramont is the latest. UNC went through their Epic conversion, I think about a year ago, because I made the mistake of going over to the UNC urgent care here on the day they were doing that, and I quickly realized the stupidity of that decision and left. And when Duke went through it, got inquiries from them as well. So the latest was the Caramont folks, and they very much were trying to figure out, they've got a huge staff at Caramont that they're trying to get trained in Epic, and I understand, and others can probably chime in, that you're looking at things like 40 hours of training or so to implement that. They were just trying to figure out ways that they could pull their shift folks in to get that training done and keep the operations moving. I mean, another option that was floated was, well, they could just completely shut down on third shift for a period of time, in which case they wouldn't be open 24/7. But the issue there obviously was then they can only do their training during third shift, and they're going to take all their first and second shift folks and move them to third shift to do the training and filter everybody back. And I do get staff, I get calls from other facilities that want, as Chris has described, to have some supplemental availability for their RMOE only function so they can put more of their pharmacists out on the floors.
So you don't get the sense that this is some move afoot, for lack of a better term, to greatly reduce the role of pharmacists in the institutional setting?
I don't get that sense. Of course, I can't get inside the heads of, but I've not gotten that sense. And more to the point, our existing rule flatly prohibits that. There's nothing today that would prevent Caramont or any other hospital facility from saying, we previously have been open 24 hours a day, 7 days a week. We're not going to do that anymore. We're going to close third shift. And if they made that decision, which would be an entirely legal decision for them to do, they could say, we're not going to have anybody on third shift now, and we'll use RMOE for everything. So they could do that now. What I'm hearing from the facilities that are interested in that is, we're not interested in reducing our 24/7 services.
So if we were going to post a rule, I would rather post a rule that is constructed by you and your team based on their recommendation. Is that?
Well, what I would tell you, Gene, is that all the proposal here is for the excision of about 6 words in there. I don't know.
Need to quantify
there's
that.
no additional surgery that I feel compelled to get in there. And do.
Right. I think it's actually words in 2 places because there's a phrase at the end of the sentence. But when this came in, I looked at it to see if I thought it was sufficiently specific to constitute a valid written request for rulemaking, because they got to tell you exactly what they want.
Right.
And I think they have done that. And while we might tweak what was on that slide, it wouldn't be much of a tweak. It would just be to satisfy.
But you would have the right or to retweak that as you saw fit. Is that right?
You're certainly able to grant the petition insofar as, it needs to be cleaned up.
Publish our own rules.
Sorry.
And it would, none of that would prohibit, I mean, look, we all have been around the block enough times with the Rules Review Commission. We know that no matter if, I don't know, whoever the high master of the English language is had constructed a rule, somebody at RORC at the end of it is going to be compelled to say, we need to change. So we have to do that anyway.
Right. So
it's guaranteed it will not be the same when it gets to the end of the process.
Right.
But Mr. Minton, I really want to address what we're seeing in the marketplace. Pharmacists want to do pharmacist work. They want to be with patients and they want to interact with patients. The problem in the acute care setting is you're too busy cranking orders to be able to move yourself into other areas where you really need that post-discharge counseling, where you really need that med recon. So where I really see this, and I'm a pharmacy champion, especially of MTM services, is the bottom line is we need to be with our patients, not cranking stuff in the pharmacy.
And I appreciate that, and I think that your presentation spoke directly to that. But as President Mixon brought out, you won't be the only one that's providing that type of service. So we got to be we need to look ahead more sometimes. That's just why I'm asking a question.
And I may, please correct me, Jay, but the board, I went through this with the board when the rules were originally written in 2010, I think.
Yeah, I think that's right.
The board has done, in my opinion, an extraordinary job of really trying to qualify who can come into the state and do it. You have the providers jumping through hoops. So I think that addresses some of those issues as well.
Thank you.
It's a pretty high hurdle coming into North
Right.
Carolina to do this.
What did you say?
I said it's a pretty high hurdle
Oh,
do it. Not an inappropriate one, and it's the same hurdle for everybody.
Yeah.
But our rules have certain checks and balances built in that aren't present. And I'm not saying the other states are wrong, I'm just saying that it's different.
But as you said, any rule change we make applies to everybody, not just.
No question
Yeah.
about it. And again, from a rule drafting standpoint, and I'm just putting on the technical legal hat here, this is about as surgical as I've ever seen anything.
Mr. President, it's time, if there are no further questions, I move that we move forward with publishing this for comment, or whatever the proper terminology
Yeah.
is.
Move it into the notice and comment.
Do we have a second?
Process.
Second.
Motion seconded. Any discussion? All in favor?
It was a pleasure meeting everyone.
Any opposed?
Have a nice day.
Thanks, Chris, for coming down. Clint and I will get the papers together to do that, and we'll do what we always do with these. And some of these good suggestions, Carol, you made several years ago. We remember that anytime we publish something for notice and comment, we're blasting it through the listserv so everybody has it. We'll make sure people see that so they'll know, because this is something I think a lot of institutions are going to be interested in. Not to say they're going to have some sort of monolithic opinion on it, but they're going to be interested in it. So,
Thank you.
thanks, Chris.
Thank you for letting me come.
Thank you.
Mr. President, I have I will say that the remainder of the items on the schedule are relatively brief. And so if it is the pleasure of the board, I would be happy to begin working through all those, and by the time the food arrives, we might be in a position to adjourn for food. And
I think that's a grand idea.
yeah, something smells like it's coming in the door anyway.
Something.
Let me give a legislative update. These are simply updates on bills that I previously talked about, and so I won't bog down in the details. Just to let you know, the biosimilars bill has now become law. I attached the final piece of that for you. Again, from a practical standpoint, there's not an immediate effect on pharmacies because there are no interchangeable biosimilars that have been approved by the FDA, but certainly board staff will put together an educational piece on this and make it available. The Good Samaritan law, the naloxone law that has passed the Senate and an altered version has passed the House, they have reached a concurrence on that. If it has not already become, well, if it hasn't already passed and been sent to Governor McCrory for signature, it will be, Mayor. Again, most of the action as it was on the Good Samaritan bill was there was substantial negotiation about immunity provisions for folks who call law enforcement who are in possession of narcotics. So that's the pieces that directly affect pharmacy relatively, well, they're not really, they're absolutely benign. One issue that is not addressed in this Good Samaritan law that I understand is getting talked about with more depth and substance is the possibility of a statutory authority for pharmacies in North Carolina to directly dispense naloxone to qualifying patients, caregivers, et cetera, without the need for an outside prescription. It seems entirely possible to me that there could be action on that in the short session. It won't happen, well, unless somebody hangs it on the budget bill, but I don't think it will. So I'll keep you posted on that. Epinephrine auto injectors, remember this is the entity level prescribing of epinephrine auto injectors. That has passed the House. It's sitting in Senate rules, or at least was last week. I do expect that's going to move at some point. I don't detect any opposition to that at all. The permit exceptions for renal dialysis products has become law. I've attached the final version of that. I'm also going to be preparing a piece to send out to pharmacies to be aware that patients can opt to have certain of their renal dialysis drugs delivered to the dialysis center in the scope of that. So that's passed. I'll get that out. Regulatory reform is the last bill that sort of most directly impacts what we do. Just a reminder that that bill would direct the Joint Legislative Administrative Procedure Oversight Committee, say that 10 times fast, to draft legislation to implement the PED report. And I think they are directed to have legislation available for consideration in January. So assuming this Reform Act passes, which some substantially similar version of what exists will pass, there are likely to be committee and subcommittee hearings over the fall in APO that will impact occupational licensing boards. Did want to point out, I can't remember if I'd pointed this out before, there is a provision in the Regulatory Reform Act that would prohibit any occupational licensing board from contracting with or employing a person licensed by the board to serve as an inspector or investigator or inspector if the licensee is actively practicing in the profession or occupation over which the board has jurisdiction. That doesn't affect us right now, as our inspectors and investigators are not licensed pharmacists. They are certainly highly trained, but they are investigators. I'm hearing different things about this, about the whys and what this was really intended to do. There's been some chatter that this was designed to deal with the dental board issue, where it came out that there were dental board members who were running investigations, which we talked about as a supremely idiotic method for 100 different reasons. That's what it was aimed at, but that's not what it says. So we're all sort of waiting to see what's going to happen with that. As you all know, we do from time to time contract with someone to serve as an expert witness or a consultant, but not as an inspector or an investigator. So I don't think this is going to materially affect what we do, but this seems a little bit broad.
There are some boards, like in contracting and building professions, where the board, as stunning as it may seem, will call the respondent's competitor and say, we'll hire you as a contract, investigator to go investigate your competition.
And there seems a not unreasonable likelihood that the competitor is apt to find lots of violations.
That seems to be a good development, but it shouldn't affect us.
I may be wrong, but I think I've heard from board members in Georgia or South Carolina that they conduct investigations.
They probably do. If I were counsel for either of those boards, I would probably say either stop doing this or find a different attorney.
But does it say you cannot hire a pharmacist to be an investigator as long as the pharmacist is working in a...
Actively practicing.
Okay, but you could still hire a pharmacist and that would be your full-time
Actively
employee and, right, okay.
Yeah, it doesn't prohibit us.
So this is all about conflict of interest.
Correct. It's a bit ham-fisted, but ultimately, yes, that's what I'm saying. And again, it doesn't prohibit us from hiring pharmacists as expert witnesses or consultants, because they, of course, don't make any decisions about what the board does. They are presented with things and said, give us your opinion. So no, I don't think it's going to impact us. But some of the smaller boards, this could be a huge impact, because while it may be a bad idea that they go out into the private marketplace and contract with people to do investigations, if they've got to do everything in-house, there's a resource issue to consider there. But that will be a problem for the shoebox boards to figure out. I'm happy to answer any questions. Obviously, budget season is in full swing, so we haven't heard much else on things. I can give you an update on veterinary reference. You all will recall that that Gigi Davidson and Emily Sora came to the May meeting and talked about veterinary pharmacy references and whether or not we needed to have an amendment to our reference library rule that spoke to that. And the direction at the end of the meeting in May was for staff to further consider the issue and provide a recommendation. It has been considered, and here's our consideration and recommendation. The reference library rule, it is certainly true that it does not speak specifically to veterinary patients, nor does it speak specifically to human patients. Mine and Clint's read of the rule is that the purpose of that rule is that pharmacies have to have an appropriate reference library to serve all patients that they serve, which could include veterinary patients if they had them. So our recommendation is that we not engage in a rule amendment, because we don't think we need to amend the rule. We think it addresses the issue. Rather, our suggestion is that staff work with Gigi and with Emily and Carolyn Arnish to develop some educational resources about what the good references are and distribute that through whatever ways that through the website certainly, and at CEs and other places. But we don't think this requires a rule change. We could get very specific, but the other thing to remember, and it's part of drives this recommendation, sometimes more specificity is good. I'm not opposed to that. But remember that anytime we propose to change one part of a rule, the Rules Review Commission looks at all the rest of it. And there's a lot of stuff in 1601. It's the sort of the spine rule for requirements for a pharmacy. And every time we make amendments to this, there's a lot of quibbling, perhaps, with different, and we'd rather not get
We
into
amended
that.
it just a few months ago, and they wanted to make a whole bunch of changes, which we successfully staved off only by telling them that it would make the rule inconsistent with other rules, and we've got the periodic review process where we've got to review them all in 2 years, so just please don't bother us now. And that was surprisingly successful. But no guarantees next time.
We'd like to maintain that record of success.
Well, there's only 2 or 3 veterinary references that would be applicable to the vast majority, and that could be handled through an FAQ.
Absolutely. And we do have an FAQ on this subject now that Gigi did several years ago. What I would propose is to work with them and say, would you guys please take a look at our FAQ, suggest updates as necessary, and also see if they would be willing to put together a one-sheet sort of thing about this issue that we could have available and distribute. I think we get a heck of a lot more mileage out of doing that than we are in going through some rulemaking process that, again, ultimately I don't think needs to happen. So if that, and we don't need a motion on this. I mean, just if you're comfortable with that, I will. And I can report to you that Gigi, Carolyn, and Emily are perfectly on board with participating in that.
Any comment from the board members? I think that's perfectly reasonable, personally.
Well, thus it shall
approach.
be done. One, let me give Gigi credit too. Bill, I know you're certainly aware of this, that the FDA has issued some revised guidance concerning the compounding of veterinary drugs from bulk substances, and Gigi volunteered, and I quickly snapped up her offer of doing this, and she produced a sort of analysis of what the new guidance was and put together a very nice FAQ on it, which we published on the website yesterday. So not that y'all didn't already know what a great resource Gigi is, but she did this in her spare time for us. So. Next item is financial report. We have on the table. Hey, Gail, come on up.
Under your financial tab, the first report is the memo to Mr. Campbell with a summary of our financials for activity for the 8-month period ending May 31st, 2015. The next report is our balance sheet, and if you'll look at line 6, our total cash is 8.1 million. And our line 44, excess revenues over expenditures for the 8-month period is 1.8 million, and total liabilities and fund balance and total assets are 9.9 million. The next report is our statement of revenues and expenditures for the 8-month period, and line 25, our total revenues is 3.9 million. Our budget to date for May is 3.7 million, and that's currently 234,000 over budget. And then our total annual budget is 3.9 million. And you'll see that we are within $300 of our total revenue budget for this fiscal year. So we'll definitely be over budget on our revenues for the current fiscal year.
Robert, just FYI, you heard Stan mention telepathy early. This is the telepathy on figuring out the revenue projections.
And then for the expenditures, line 74, our total expenditures for the 8-month period is $2.1 million. The budget is to date is 2.3, and we're currently 207,404 under budget. And then our total annual budget for expenditures for the fiscal year is $3.4 million. The variances are, the largest variances for expenditures is inspection expenses, which is currently $24,000 under budget. And that's due to the change in personnel and the changes in the inspection department. And then legal fees and vehicles are also have large variances, but that's due to the invoicing compared to the budget, because we will be over budget on vehicles because we've ordered 3 and just budgeted 2. Does anyone have any questions about the financials?
This is not directly related to the financial report, but Stan, you had asked with respect to potential ACPE costs, what the upside additional costs might be. I did get an email on that and $2,000 will be the maximum exposure, so we can just plan for that in August.
And also under the financials, we wanted to, currently our capital assets are recorded at cost, and property and equipment are capitalized if their life is expected to be greater than 1 year, and their cost is $500 or greater. So we would like to raise the $500 to $2,000, and this has to be approved by the board because it's one of the statements in our annual audit report. So we recommend going to $2,000. The range right now for most boards is $1,000 to $5,000.
What it means right now is we're capitalizing every computer, every laptop computer we buy and all the like. These are not capital expenditures, and it's a hassle.
Not anymore.
So moved.
Wait, does that need a motion?
It does.
Second? Second. All in favor?
Aye.
Aye.
All right, thank you.
Opposed? No.
Thanks, Gail.
Opposition.
All right, Joshua.
All right, behind the investigations tab, you can look at the number of complaints. Up to the 12th of June, we're at 112. Once again, in the leads, the procedural legal types and diversion and errors are the same at 29, which is a little troublesome. Then inspection follow-ups, and then incident reports. But things are moving along very well. We're pretty much on track, probably going to hit 300 again this year, complaint-wise. Behind that, you see the surrenders, and of course, technicians always lead the pack on that one. And pharmacists are not too far behind, and then pharmacies are at 2.
Can report also that as of June 1st, we have operationalized the new territories and the new personnel, and thank you again for your support on that.
Absolutely.
We've made all of our hires. We have everybody in place.
Yeah.
So
We have 2 hires here today. Summer Canoy, she's going to be inspector for the northeast part of the state. And Sandra Burns-Knuckles, she's going to be the inspector for the northwestern part of the state.
And Sandra was previously.
Sandra is a previous employee here. She was here about a decade ago and stayed for about 4 or 5 years. And we were lucky enough to get her back.
Would you guys like to make a speech to the board members? I'm saying they did not take the
Maybe later.
invitation.
Thank you, Jason.
Josh.
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 I call him much worse things every day, so. DME subcommittee election update. I don't think there's much to report. Cindy accepted there is one candidate for that slot, and there's been one vote received for that candidate, so I rather expect that we know what the outcome of that one is going to be. I will update real quickly. As you all know, we are in the middle of a runoff for the Southeastern District Board member seat. Kristen, of course, is continuing to handle that. I do appreciate your availability on June 24th to convene by conference call to do that. But I understand that there has really not been, not only I think not been a drop-off, but there's been an increase in the number of votes cast going into a runoff election, which will be the first time that's ever happened. So we will see. The voting again closes 1 week from today, and then we'll convene on Tuesday. A reminder, just a reminder, NABP District 3 registration is open for that now. Cindy, if all of you are certainly invited and encouraged to attend if you can. It's in St. Augustine, Florida. Feel free to contact Cindy with any requests you might have to help with registration, travel plans, any or all of the above. Reports to the board. I know Dave is here. Mike's here. Come on.
I may, that's always a
You
good.
sculpt in, Mike.
Multi-gunner is the best one.
Good afternoon.
Hello.
Happy to be here. Mr.
We're
Graves,
happy to have you here, Mike.
Mr. Haywood, these two gentlemen have sit since I got here last time. So, I would tell you that I just left an exciting place. I just left the Senate Appropriations on the budget. So they're trying to decide what they're going to do. And as I left, they were waiting on amendments to come in. So I will race back, and hopefully we won't see any pharmacy amendments. They're taking a drastic change, as you probably already know. One of the things they're doing in the Senate, as opposed to the budget, is they're going to cut the number by about $700 million. And a lot of that is coming from not putting money in the rainy day fund and things of that nature. You're not seeing any real huge cuts that the House had put in their budget from a standpoint of what I consider to be day-to-day type objects. Most reserves, things of that nature. They're trying to lower the income tax rate, as you've heard. They're trying to figure out ways to get that money back through fees. You've heard they're talking about tax on advertising, tax on general things such as mechanical repairs, car repairs, things of that nature. So you're seeing them head more in that direction to try to shore up the loss of revenue through the tax process. I think in the pharmacy standpoint, the biggest thing we're talking about is Medicaid. Medicaid is, from the House budget, is a budget that is a bill that says we're going to continue to do Medicaid pretty much as we've seen it. They're calling it an ACO. Well, what I need to tell you, so when you hear this, you'll know, is that ACO terminology has been changed to PLE terminology. So if you hear PLE talking, they're talking about ACOs. And that's provider-led entities is what that stands for. So they're going through that process. The Senate has stood by since last year when they really had a problem with the budget trying to get this done, has stood by the premise that they want managed care to come in and take over the program. And they want it to be so they can look at the cost as a check write, so to speak, and say we can write one check a month. That's going to cover all Medicaid. We don't have to worry about the rest of it. The problem they can't answer for you is if that managed care company runs out of revenue when they wrote that check, what are they going to do? You know, if they get into September, October, and the money's gone, you have to believe the managed care company is not going to pick up the dollars. So those are things they're trying to look at now and try to see what they're going to do. But you've still got a real mix because the House doesn't want to do that at all. House wants to go the PLE route. Senate wants to go managed care. So in the budget that just came out this morning, it says in there that they're really going to do it a little different way in the fact that they're going to have 3 statewide entities, maybe managed care, maybe some maybe UNC or somebody like that that comes up and puts a program together. But they're going to have 3 statewide entities. Then they're going to have 6 districts or regions, and each region is going to have 2 PLEs in it, and it could come from anywhere. Whoever, doctors and nurses want to put one together, pharmacists want to put one together, hospitals want to put one together. Anybody that wants to put one together can have a PLE as long as it meets all the criteria of the state. All of them are going to be responsible. It's going to be one check fits all, so to speak. So it's not going to be any different in the revenue portion than it is in anything else they're doing, but it's going to be devised a different way than the House. The House is actually saying that they want to have regions. They just don't have the details, relatively speaking, that the Senate has at the current moment. Now, where we are in all this is that the Senate is going to pass this budget. There'll be some amendments. I think there'll be few. I think some of them will pass, some of them won't. And I don't think any of them will change the budget anything like the significance that some of them would like to see it change. So with that said, I think you're going to see them rush through the day-to-day. Probably by 3 o'clock, they're going to have the bill on the floor of another committee, Finance, then Retirement after that, and probably you're going to realize that they're going to figure out a way to get this bill on the floor, on the Senate floor by tomorrow, which kind of is obviously a special process because it usually takes 2 days to get from committee to the floor. So the logic is now that it's going to be Wednesday, Thursday, and then shortly after that, they'll obviously have differences and they'll go to conference. You've still got the problem with the Medicaid situation because the House has got a separate bill that addresses Medicaid. Senate has put it in the budget. So when they get to conference, the question is going to be, can the Senate convince the House to roll it into the budget or vice versa? If that's not the case, then you've got to go through that process. You've also got to go through the tax situation. So I feel like that we're going to probably be at the legislature into August, if not longer, depending on who really decides they're going to stop everything in place. And I don't think there's any way we're going to have a bill by July the 1st, which is the end of the fiscal year. So we'll get a continuation probably through the legislature, and they'll continue to operate as they are today until the time the new budget comes along. So that's kind of the real things that are going on. There's lots of other small odds and ends going on over there, but the main focus, as Jay said a while ago, has been the budget recently, and it will be until they figure out where they are. Once they get it into conference, other things will be addressed in committees and things of that nature. One of the reasons you see the epinephrine bill, I think it was, that is tied up in rules is because anything pretty much that's come from the House and gone to the Senate has gone to rules.
Yep.
So they're sitting
Is
on.
there 400
Yeah, like
bills?
400 bills and rules. And I think part of that is a bargaining chip. And I think part of it is they just didn't want to address it till they got some of the other things out of the way. And you'll start seeing some things in the Senate move very, very quickly, I think, once conference starts on the budget. So we'll see how that goes. And I know I'm holding up lunch, so I'll stop here. And anybody any good questions? Wish us luck. That's my.
Good luck, Mike. Thank you.
Thanks so much.
Thanks, Mike.
Yeah,
Good to see
thank you.
Board members, that leaves, we do not have any items for closed session at this meeting. That leaves then the consent agenda, and if I could beg your indulgence, I have one additional item for the consent agenda, and I'll explain, Janice will familiar with you what that is. In addition to the items that were provided to you in advance, we have an applicant for licensure in North Carolina, who you'll see here. He had a background that required consideration of his eligibility for licensure. Mr. Minton graciously agreed to stay above and beyond the prior call of duty to hear that matter at 5 o'clock yesterday. At the conclusion of that matter, there was a recommendation of a consent order regarding eligibility for licensure from Michael Cole Harrell, which is before you. Mr. Harrell, or Dr. Harrell, excuse me, has agreed to that, and it's on the table for you. The short of this is that Dr. Harrell was found to have had an alcohol abuse problem while he was in pharmacy school.
He has been a PRN participant voluntarily since 2014. He has had some non-compliance issues, which are detailed here, but there was discussion of that, and Valanda can answer any questions if anybody has it, or Jennifer can. Notwithstanding that, it's PRN's opinion that those issues, while significant, were not born of relapse into substance abuse. So the order would make this candidate eligible to proceed through the licensure process, and if he successfully completes that process, his license would be subject to 3 conditions. One, that he successfully complete his PRN contract, and that any noncompliance would be reported to the board's executive director throughout that process. Second, he would not be able to serve as a pharmacist manager for a period of 1 year, and he can only practice pharmacy the number of hours per week deemed clinically appropriate by NCPRN. Staff is certainly comfortable with this consent agreement. I do believe Mr. Minton was as well yesterday, and so I did want to, obviously the issue here is that he is a 2015 graduate, and we're trying to make a decision on his eligibility for licensure so he could undertake that process now. So if we could deem that to be an addition to the consent agenda.
Mr. President, make a motion, we accept the consent agenda with the additional that Mr. Campbell just presented.
Is there a second?
Second.
All in favor?
Aye.
Aye.
Any opposed? Passed.
I believe Mr. Mixon had a presentation you were interested in presented by the Pharmacy Compounding Advisory Committee.
What's the will of the board? I have a short presentation on the upcoming Pharmacy Compounding Advisory Committee at FDA, which is taking place tomorrow. I'll make it brief if you're interested in hearing about it. Also, I wanted to say in terms of the Pharmacy Leaders Forum, the names that were submitted, I finalized that list. I do want to mention that we only have 15 slots. So in the future, if you submit 5 names, clearly it's not likely that 5 names are going to get selected. I mean, it's not fair. We don't have enough slots for 6 board members to nominate 5 names. So there has to be some narrowing of that list. Nonetheless, I have finalized that list, and I'll send it on to
If you'll
Jay.
send it to me, or really send it to Leslie, and she'll get everything out.
And I believe everybody that was nominated is on the list, so but there was some concern about it. Cindy, can you bring up that PowerPoint and flip the lights out? The meeting, I'm flying to Raleigh this afternoon, to Washington from Raleigh this afternoon to attend this meeting tomorrow and Thursday of this will be the second meeting of the new Pharmacy Compounding Advisory Committee. We're going to hear about the expanded access to investigational drugs. Thank you. And we are going to consider 4 additions to the do not compound list. We're going to discuss 4 substances to be included on the positive list. And the item that's the most curious to me is discussion of the demonstrably difficult to compound. Oops, I'm sorry. Let me get to slide 24. I did this presentation for you earlier this year. Then I added to it for the meeting of compounders on Capitol Hill. We just got the information for this meeting via the Federal Register. Curiously enough, even members of the committee were not emailed the link to the information, but there's no use crying over spilled milk there. The 4 drugs that are considered for the do not compound list are listed here. Aprotenin, which was marketed under the trade name Trazolol. Some of you may remember that. I have never dispensed it personally. Ondansetron in IV doses greater than 16 milligrams. Bromocriptine, but only for the prevention of lactation, and any oral dosage forms of acetaminophen that contain more than 325 milligrams per dose. there are, the FDA has received a lot of recommendations for the list of drugs to be added to the bulk drug substances list that are approved for compounding. That list was narrowed down by FDA to 64 bulk drug substances, and the way they narrowed it down was whoever nominated the drug had to provide sufficient evidence for evaluation for inclusion on the 503A bulk substances list. And in a minute, I'll have a slide that talks about how what criteria are used. So the 4 substances that we're going to talk about, I believe, tomorrow afternoon are Brilliant Blue, Tranilast, N-acetyl-D-glucosamine, and tryptophan, also known or better known as hydroxytryptophan. FDA's recommendation for these drugs are to add Brilliant Blue, do not add Tranilast. And Tranilast has been used orally as a mast cell stabilizer, and there are some adverse events, but it's also used topically, and it has a good history and safety profile topically. So hopefully we'll get the FDA, or get the committee, we'll be able, as committee members, we'll be able to convince the rest of the committee that it is useful topically. FDA recommends N-acetyl-D-glucosamine be added and 5-HTP not to be added. And if this meeting goes like the last meeting, FDA's recommendations will prevail. So we're going to also talk about the criteria that FDA proposes that the committee use to evaluate drugs for identification as demonstrably difficult to compound. The 6 broad categories are complex formulations, complex drug delivery mechanisms, complex dosage forms, bioavailability, compounding process complexity, and physiochemical or analytical testing complexity. And if you take a broad stroke, this could include just about every drug that's compounded. Complex formulations, I'm not going to read all this to you, but may include those formulations where the APIs have unique properties, or there may be crystalline forms or particle size differences or things that are critical to the safety and efficacy, and this complexity makes it, more likely that an adverse effect on safety could occur. Again, I can think of many compounds that we compound every day that could fall into that category. Complex drug delivery mechanisms such as coated beads or polymeric matrices or liposomes. I don't know of any compounder that does compounding with coated beads. I mean, unless we take a commercially available capsule of something that's a sustained release preparation that can, in the capsule there's coated beads, and we may pull that capsule apart and make a lower dosage form, but we wouldn't be changing anything other than the number of beads in the capsule. Complex dosage forms. One of the drugs that was listed by one of the companies is or nominated as demonstrably difficult would be the Advair inhaler or some other propellant inhaler. And I just don't know of any compounding pharmacists who try to duplicate Advair inhalers or use a propellant-based aerosolized, make a dosage form that's aerosolized. That's just not what we do. Bioavailability obviously is very important. Compounding process complexity, such as multi-particulate dosage forms of solid oral beads that require wet granulation, extrusion, drying, coating, curing before being processed. Again, this is not what compounders do. So clearly this list is nominated by manufacturers, or manufacturers had a lot to do with coming up with these criteria. And physicochemical or analytical testing complexity may include assays that are cell-based assays, testing using NMR, mass spec, and/or X-ray powder diffraction. Who knows what that is in this? So these are the criteria. Again, how the discussion is going to proceed is a good question. Here's a part of the list that was nominated and who nominated it. Some of these are clearly like Axelium has they're coming to market with a commercially available form of alprostadil with papaverine and phentolamine. So they're trying to protect potential market share. Why atropine would be considered demonstrably difficult, I don't know, other than, again, to protect market share. I mean, atropine's not difficult to compound. Azithromycin, baclofen intrathecal by Mallinckrodt. BHRT pellets, I mean, I can understand that. Public Citizen nominated a lot of drugs like dry powder inhalers, enteric-coated preparations. Here's a Dr. Utian who has, look at the initials behind this guy's name. MB, BCH, PhD, Doctor of Science, et cetera, et cetera, et cetera, including being a frog. Estrol, high-potency drugs, low-potency drugs, modified release drug products, nitroglycerin ointment, non-sterile to sterile compounding. Progesterone. I mean, it's almost comical what has been nominated. Wellbutrin SR, I don't know of any compounders who really try to copy Wellbutrin SR or Zyban. And there are plenty more on the list. And that information is available on or all this briefing material for the FDA committee is available on the web. Thank you.
Thank you. Appreciate your being a representative on this important committee.
You're welcome. I believe that concludes our business.
It does. Staff has no further matters.
Motion for approval? For
Motion to be adjourned.
adjourn, thank you.
Second.
All in favor? Aye. Meeting is adjourned.
Stan.
You guys all stay for lunch, please. It's
If you got that.
back there and it's available.
You got your certificate for that?
I think it's in the truck. I'll go get
Grab
it.
that for me.
I'm
Yes,
pretty
sir.
sure it's in the truck.
Yeah, I did.
Appreciate you
Yes,
doing
thank
that.
you.
Oh, yeah.
I mean, I know it's not a hard thing.
It's about 2 hours. It's not an hour.
Well,
It is. I've learned a lot already. Enjoyed it.
I'll go down and get that and bring it back up.
You gonna see Drew while you?
Sir?
Gonna see Drew while you're here today?
I talked to him last night as I came in, and so I probably won't see him this afternoon. He says he's making a living. I don't know. He's got to work.
He's not asking you for money.
No, he's not. He's not asking me for money. I offered to buy him supper, and he didn't want to take me up on it. Mike, who's going to win the war?
Did you see the end of Vanderbilt and Fullerton game yesterday?
Expert committee members
Anchor down, baby. Anchor down.
and returning expert committee members that if
Those games are pretty good
USPs,
Well,
the Monday and
Vanderbilt
Tuesday.
better think whatever weather god, because that game the other day,